Good afternoon. It is my pleasure to welcome all the participants, speakers, and guests to the second day of the 3-day postgraduate course on anesthesia and the cancer patient. This postgraduate course has surpassed the various challenges of the pandemic as a vibrant way for the departments of anesthesiology and perioperative medicine of the University of Santo Tomas Hospital and the Faculty of Medicine and Surgery to celebrate its Diamond Jubilee and the Sesquicentennial, respectively. The current health crisis is an unprecedented call that shows us how crucial it is to revive our pursuits toward continuing medical education. The digital platform is not an impediment to improve our perioperative care of cancer patients. The plethora of topics from our speakers and their wealth of knowledge and expertise make this endeavor truly successful. It is my hope that we can take advantage of this second day of opportunity to come up with valuable contributions and recommendations beneficial to our patient care. I wish everyone a most successful engagement. Thank you, and God bless us all.
Good day to all. It's my privilege and honor to give you a little something. Well, how I started in anesthesia.
There has been a quantum leap in anesthesia management, post-operative and intensive care, then and now. The tremendous progress and advances in technology, drugs, and monitoring devices that made cardiac surgery a lot safer.
Anesthesia has gone a long way with the modern equipment available. Professional care you give your patient can never be replaced by anything mechanical or any new scientific gadget. put everything into it.
To the new graduates and those in training, remember, set aside some time to share your expertise to the less fortunate ones. Thank you.
I think that's all I can tell you for now. Thank you.
As if handling a patient with both cancer and cardiac disease isn't already challenging enough, with our current situation in this pandemic, we add another C, COVID. Colleagues and friends, I am privileged to introduce our beloved speaker for today's Romarico Suarez Commemorative Lecture on Cardiac Anesthesia and Perioperative Medicine. Like the sands in the sea, I cannot possibly enumerate all of her achievements. But to name a few, she is the former chair of the Anesthesia Department of the UST Hospital, a past president of the Philippine Society of Anesthesiologists, a past chairman of the World Federation of Societies of Anesthesiologists Executive Committee, an awardee of the prestigious Professor Quintin Gomez National Award, and currently the Division Chief of Cardiovascular Anesthesia at the Philippine Heart Center. To add to her already brimming cup, she recently graduated summa cum laude from the Master in Business Administration program of the Colegio de San Juan de Letran. If Dr. Romarico Suarez is our tatang, our dear speaker is our mama. Like a mother, she always pushes us to be better, always challenges us to aim for excellence, and is always present whenever we need her. Ladies and gentlemen, let us all welcome Dr. Florian R. Nuevo.
Ladies and gentlemen, good afternoon. Before I proceed with the lecture, allow me to share a short background about UST Anesthesia Postgraduate Honorary Lectures. It all started in 2010 during our 7th postgraduate course when the UST Anesthesia leadership has decided to create honorary lectures during postgraduate courses. These are the two main objectives for this decision. First is to give distinction to Thomasian anesthesiologists who pioneered the advancement of anesthesiology in both academic and clinical domains here at the university and beyond. Second is to highlight lectures on recent developments in the basic sciences related to anesthesiology and its subspecialties. This slide shows you the timeline of these honorary lectures, two of which we now label as commemorative lectures. In 2010, I had the privilege of delivering the first Romarico Suarez Honorary Lecture and presented the history of cardiovascular anesthesia in the Philippines. Dr. Suarez was a senior resident when the historical first open heart done by Dr. Denton Cooley happened in 1959 here at the University of Santo Tomas Hospital. We bid goodbye to you, Dr. Suarez, last May 9, 2021, but your legacy lives on. Today, I am sincerely grateful to the organizing committee for allowing me to honor you once again with this lecture on the triple C, cancer, cardiovascular disease, and COVID. In the next 15 minutes or so, we shall touch on these talking points. What are the implications of cancer survivorship in our practice? Is there an association between cancer and cardiovascular disease? And how do we frame the anesthesia management of cancer patients with cardiovascular disease in the context of the pandemia? As seen on this press release last March 21 on all-cause mortality, ischemic heart disease ranks number 1, followed by neoplasms. And in 2019, there is a notable increase in the pneumonia as a cause of mortality. And in 2020, an added category for unconfirmed cardiac was ranked at 7th position. I wonder how this ranking shall now appear for year 2021. 50% of malignancies is contributed by cancer of the breast. And in terms of death rates, the mortality rates are almost the same for breast cancer and lung malignancy. Take note as well that for the same category of disease, such as lung cancer, colorectal cancer, and liver cancer, the males have a higher incidence compared to females. There is a reported 16% risks of developing cancer before age 75 for both sexes, with a slight higher risks of dying before age 75 for the male. We also see here the top 5 cancer pathology between males and females. Lung cancer followed by colorectal, prostate, liver, and leukemia are for the male gender, whereas for the female, the highest is breast cancer followed by cervix, colorectal, lung, and ovarian malignancy. In one local study done by the Perlaudico in 2010, it was observed that the Filipinos residing in the Philippines has a much lower rate of cancer survivorship compared to the PhilAms and other Caucasian race. And this is particularly sad for lung cancer, followed by breast cancer. It is only with thyroid cancer survivorship which look quite optimistic at 80% survivorship. This figure shows the trend in cancer survivorship. It is evident that there is an increasing trend with an estimated 26 million survivors by the year 2040. Majority of these survivors shall be past 65 years into their 70s and 80s age bracket. What is the relevance of this information? Well, this information should alert clinicians and hospital administrators to develop services for geriatric medicine, cardio-oncology, and for us in the anesthesia community to seriously consider oncologic anesthesia. These 3 areas should now be part of the continuum of care for cancer patients in the next decade if we want to improve cancer survivorship in our country. With improved cancer survivorship, we also need to be aware of the long-term effects and late effects of cancer treatment. Highlighted in bold letters are those which I believe are relevant to us, such as chronic pain, peripheral neuropathy, cardiac dysfunction, cognitive dysfunction, and the occurrence of osteoporotic fractures or even the development of second primary tumors in cardiac survivors. In a nutshell, cardiac survivorship bring about these implications to our clinical practice. We are faced with aging patients who are frail, with risks for cognitive dysfunction, depression, and anxiety, and also from the effects of cancer treatment. Let us now focus on the possible effects of cancer drugs on the heart. The multiple hit hypothesis have been put forward as the framework for understanding cancer therapy-induced cardiac dysfunction. In general, patients with pre-existing cardiovascular disease and poorly controlled cardiovascular risk factors, coupled by exposure to cardiotoxic agents, they are placed at a high risk for cancer therapy-induced cardiac dysfunction. We can classify the factors that influence these risks to cancer therapy into 2 groups: drug-related factors that includes the type of drugs, the combination of drugs used, the doses, and the route of administration. For patient-related factors, aside from what have already been mentioned, we need to consider the history of exposure of our patient to radiation therapy. It has been shown that radiation to the thorax can damage the pericardium, myocardium, the valves, and coronary vessels. Because of this injury to the endothelium or fibrosis of the pericardium and myocardium brought about by radiation. Coronary artery disease is the most frequent complication post-radiation therapy. Its incidence becomes higher in patients with pre-existing ischemic heart disease. It has also been observed that the mean interval time between radiation therapy and cardiovascular complication is 6 years. Chemotherapy agents may be given before surgery, during or after surgery, or simply as part of the palliative care regimen. Hypertension, arrhythmias, cardiomyopathy are the commonly associated cardiovascular complications of chemotherapy, specifically noting the anthracyclines to be related to this cardiotoxicity. This table highlights the effect of anti-cancer drugs on the cardiovascular system. Manifestations include tachycardia, bradycardia, or rhythm problems, hypotension and hypertension, and the worst complication being cardiomyopathy, which if not diagnosed early can develop into frank heart failure in the long run. Thus, when attending to cancer patients, we need to make a good medication review at all times. We must also be aware of the drug interaction of chemotherapy agents with seemingly benign drugs that we use intraoperatively. Let us watch out for drug interactions that alter the pharmacokinetics of either group drugs. As shown in this table, let us take fluorouracil. In the presence of phenytoin, what happens is an increased plasma phenytoin concentration. But in the presence of cimetidine, the increased plasma concentration is that of fluorouracil. Acetaminophen, a benign drug in the presence of imitamide, shows that the breakdown of acetaminophen is reduced. Let us now explore the association of cancer and cardiovascular disease. There are currently 4 accepted biologic mechanisms. Inflammation is a major mechanism for both cardiovascular disease and cancer. Another common pathway is the oxidative stress and lipid peroxidation pathway. The role of hormones, cytokines, growth factors, and other metabolic reactions have also been identified. The shared biology of obesity, cardiovascular disease, and cancer is complex. Pro-inflammatory cytokines and hormones produced within adipose tissues are elevated in the serum of obese people. Adipose tissues produce abundant interleukin-6, which also stimulate the hepatic production of C-reactive protein, another inflammatory marker for cardiovascular disease. And here are the other factors identified from adipose tissues which exhibit angiogenic and tumorigenic effects. Likewise, angiogenic factors are alluded in hypertension, including elevated levels of VEGF and angiotensin II. Hypertension affects the arterial walls through the oxidative stress, which is also associated with carcinogenesis, suggesting that oxidative stress is another possible biological pathway shared by cardiovascular disease and cancer. And recently, the cholesterol metabolite 27-hydroxycholesterol has been implicated in breast cancer. Now, the enzyme that produces this metabolite is found to be abundant within tumor-associated macrophages. With certainty, smoking is a common denominator for cancer and cardiovascular disease, and basically the mechanism is related to the development of carcinogens, pro-inflammatory stimuli, and other oxidizing agents. Genetic mutations in the folate mechanism pathway, particularly in conjunction with inadequate folate intake, this has been known to be associated with an increased risk for colorectal cancer and cardiovascular disease. On one hand, omega-3 fatty acid use is popular to have positive effects for reduction of cardiovascular disease. There is not yet a good systematic review to endorse this proposal for the reduction of the risks of cancer. And for the shared biology of physical activity, cardiovascular disease, and cancer, the current evidence supports weight control as an important role in reduction of the incidence of cancer and cardiovascular disease. In summary, risk factors can either be modifiable or non-modifiable. Note that age and disease onset are highly influenced by lifestyle parameters. And in this EPIC study conducted on over 23,000 participants aged 35 to 65 years of age, a follow-up study on this group of patients after 7 to 8 years disclosed the absence of cancer or the increased risk to cardiovascular disease. And these lifestyle behaviors include never smoke, a BMI of less than 30, physical activity greater than 3.5 hours every week, and a healthy diet. Now let us focus on framing cancer and cardiovascular disease in the context of COVID. These are the 3 C's, sharing 7 risk factors, namely advanced age, hypertension, diabetes, dyslipidemia, obesity, smoking, and cardiovascular disease. We know that COVID-19 can cause cardiovascular disorders like myocardial injury, arrhythmias, acute coronary syndromes, and venous thromboembolism. And the presence of underlying cardiovascular comorbidities in patients with COVID-19 is also associated with a high mortality. The interaction of the protein S spike on the coronavirus COVID-19 virus, its interaction with angiotensin converting enzyme 2 of the human body, this leads to the development of cardiovascular complications of COVID. On one hand, COVID and cancer separately by itself show characteristics of being pro-inflammatory and pro-coagulant. So together, there is an enhancement of these pro-inflammatory and pro-coagulant states. And earlier, we have expounded on how cancer therapy affects the cardiovascular system. Thus, the presence of the triple C, cancer, cardiovascular disease with threats of COVID, can truly present a difficult and stormy clinical situation. Realizing, therefore, the relationships of cancer with cardiovascular disease during this time of the pandemic, we must get ready for the Great Reset. We need to appreciate our greater role as perioperative physicians and participate in the care of cancer patients more proactively. Let us consider our essential role in the pre-operative preparation, particularly in the optimization of education. Let us be proactive leaders in building interdisciplinary teams with a common goal that is improve patient outcomes, or at the very least, a better quality of life for our cancer patients. Hospital services must seriously consider developing the cardio-oncology care to supplement its cancer care programs during this pandemic and beyond. Such can facilitate proper planning of utilization of various resources as shown in this video. This slide shows the recommended management plans for cancer patients presenting with either cardiomyopathy or ischemic heart disease. You are allowed to take a screenshot of this slide. In the interest of time, I can no longer discuss each category. Be it known, however, that central to the optimal management of cardiovascular complications is the consistent monitoring of these disease processes. Here is another table showing the recommendations for hypertension, thromboembolism, or QT prolongation, including radiation support. You may also take a screenshot of this slide. So what I want to emphasize, therefore, is that monitoring is essential for the timely management of cardiovascular complications among cancer patients. Biomarkers can be used to monitor the state of cardiac function. Troponin indicates myocardial injury, while brain natriuretic peptide is a good biomarker for heart failure. And for assessment of ventricular function, we can go for the modalities of repeated echocardiography monitoring. If there is myocardial strain measurement, then it's better. We can also ask for radionuclide angiography or CT angiography to assess left ventricular dynamics. Here are 4 guidelines that we may find useful in framing the management of cancer patients with cardiovascular disease. A preoperative assessment to identify any side effects of treatment is required for all patients with a history of cancer. We have to devise a structured intraoperative and postoperative management plan in collaboration with the surgeon and oncologist. And the interval between the end of neoadjuvant chemotherapy and surgery depends on the type of cancer and the threat to life. This again must be discussed together with the surgeon and oncologist. And lastly, a treatment plan aimed at choosing the best interval for surgery to avoid the acute side effects of chemotherapy. This should be discussed with the oncologists. Framing cancer care during this time of pandemia, we follow these current guidelines. For elective procedures, as much as possible, we deal only with recovered COVID patients, at least 7 weeks post-recovery, and at least 7 weeks post-vaccination with the negative swab test. However, for urgent and emergency procedures that are truly life-saving or limb salvaging, then logistical support must be given to ensure a safe environment for the healthcare team, for the patient, and also advice on the family on how to continue care even when they are home. These are my personal recommendations for anesthesia management and perioperative care for cancer patients with cardiovascular disease with the threat of COVID. Number 1 is to plan for stress-free anesthesia. Last Wednesday, we have heard how anesthesia can be further improved to help cancer patients. We must understand the effects of our anesthetic agents and look for best techniques. We may even use combined techniques to ensure that we provide the best stress-free anesthesia plan. Let us take a look into the use of our drugs and aim for organ protection, aim for somatic and visceral analgesia, and lastly, let us not forget to aim for the mental wellness of our patients. Second, let us apply relevant evidence-based enhanced recovery after surgery protocols. It is best that we are able to send home our patients early. If ambulatory procedures can be done, then why not? So cancer patients need all the compassion and collaborative care with the family members is most appreciated. Lastly, let us encourage to have an early integration of expert management and palliative care, both for the cancer pathology and the heart failure that these patients may be experiencing. So to help us in our anesthetic and perioperative care, let us pursue for organ system monitoring. The triple C in the Great Reset for me means that we apply the evolving paradigms in the perioperative care of cancer patients, all geared towards learning new ways of improving patient outcomes. Let us develop the mindset of perioperative physicians with the patient at the center of it all. Again, my dear friends and guests, may I present to you our beloved Dr. Romarico D. Suarez. Thank you, Dr. Suarez, for being a role model to us. Indeed, you were ahead of your time, for I have personally witnessed on how you have applied the dynamics of perioperative medicine in clinical anesthesia practice. And to all the participants who joined us this afternoon, thank you very much for listening. Enjoy the rest of the meeting and please stay safe.
Thank you very much, Dr. Nuevo, for that very illuminating talk. Dr. Suarez is surely watching over us. Let us welcome Dr. Nuevo. Are you here? Dr.
Yes,
Nuevo.
Roxanne.
Hi,
I'm here.
Dr. Good afternoon po. Thank you for a very illuminating talk. We would like to present to you the University of Santo Tomas Faculty of Medicine and Surgery and the University of Santo Tomas Department of Anesthesiology and Perioperative Medicine would like to award the Certificate of Appreciation to you, Dr. Florian Arnuevo, for sharing her knowledge as honorary speaker for the Dr. Romarico Suarez Commemorative Lecture on Cardiac Anesthesia and Perioperative Medicine during the 13th postgraduate course in Anesthesiology. Anesthesia and the Cancer Patient, Evolving Paradigms in Perioperative Care, given this 8th day of September 2021, signed by Arthur Joseph Marquez, Michael Madarang, Aniela Sullivan, and our chair, Dr. Elvira Milo. Thank you for joining us, Dr. So for our next topic on perioperative blood management in cancer patients, we have an exciting panel discussion with two experts in two different fields, after which we will be having an open forum. So please feel free to type in your questions in the Q&A box. So for our first speaker, he's a graduate of the UST Faculty of Medicine and Surgery. He had his residency training in internal medicine at Jose B. Linad Memorial General Hospital. He had his subspecialty training in adult hematology in UST Hospital. He is a fellow of the Philippine Society of Hematology and Blood Transfusion and is a former faculty in the Department of Medicine in UST. He's a friendly and endearing presence in our hospital. Ladies and gentlemen, Dr. Jomel Julian. And together with Dr. Julian is a colleague who also graduated from the UST Faculty of Medicine and Surgery. She had her residency training in anesthesiology in UST Hospital and her fellowship training in cardiothoracic anesthesiology at Singapore General Hospital. She is a member of the Philippine Society of Cardiothoracic Anesthesiology. She is a favorite among the residents, I think, beloved by all her colleagues and OR staff, and a very dear friend, Dr. Ina Christine Caiton. They are joining us now live together in the UST hospital. Welcome, Dr. Julian and Dr. Caiton.
Good afternoon, Rox. Thank you for that very kind introduction. Good afternoon, ladies and gentlemen, colleagues. We are tasked today to discuss on the perioperative blood management in cancer patients. Ina?
Thank you for being here, doctors, at Live na Live in UST.
Okay, I think we're having some technical difficulties.
We're having a few technical difficulties while we wait for the slides. Okay. Welcome, Dr. Ina
Cancer
Caiton and Dr.
patients
Julian.
presents as physicians with a task of maintaining the balance between the risk of bleeding and the risk of coagulation. We have the responsibility of maintaining adequate blood composition while trying to prevent further aggravating the risk of thromboembolism. So we're here to present a perioperative blood management of a cancer patient presenting for surgery.
Okay, so here we have a case scenario. JD, a 67-year-old male who presented with melanoma, diagnosed with gastric malignancy stage 2A, who underwent chemotherapy. He is now scheduled for gastric surgery. So he has a BMI of 18, with hypertension, a non-smoker, non-alcoholic beverage drinker, with stable vital signs but pale conjunctiva, hemoglobin of 98, hematocrit of 0.28, WBC of 256, and platelet of 366. Sodium and potassium are, sodium is 138, potassium 4.35, PT, APTT, INR, PT 12.1, APTT 30.6 seconds, and INR of 1. So for this case scenario, what are our considerations in cancer patients scheduled for surgeries?
So Roxanne,
Let's start with Dr. Caiton.
the presence of malignant disease doubles the risk for DVT and 4 times the risk of fatal post-operative pulmonary embolism without a perioperative thromboprophylaxis. This is due to the presence of the tumor, the mechanical effect of the tumor on the blood vessels, and the effect of chemotherapy. So 40% of VTE events occur within 21 days of surgery, and it is responsible for 46% of deaths within 30 days of surgery. Systems have been used to try and predict the risk of VTE in cancer patients, one of which is the Khorana scoring, which is a clinical prediction score developed to identify ambulatory cancer patients at high risk for venous thromboembolism. So high-risk patients have a score of 3, intermediate risk patients have a score of 1 to 2, and the low-risk patients have a score of 0. Based on the Corona scoring, our patient is classified as a high risk of developing venous thromboembolism.
So, Dr. Julian, how do we provide prophylaxis for our patients?
So, the European Society of Medical Oncology provide recommendation to help patients with the best care option. So after identifying that these patients are categorized within the high risk groups, pharmacologic prophylaxis in the form of low molecular weight heparin or unfractionated heparin can be given monotherapy or in combination with mechanical methods. So the NCCN guidelines provide us with cancer-associated thromboembolic events. We have to determine first before giving the type of regimen we want. We want to first recognize the renal status of the patient. Is the patient going to be given inpatient or outpatient? What about the cost, the the ease of administration, our ability to reverse this or the bleeding risk of this patient. So these are some of the pharmacologic prophylaxis that we can give actually. No, we have your dalteparin, your enoxaparin, fondaparinux, unfractionated heparin, and apixaban. If you're going to see this slide or focus this slide, you have the starting dose, and this should be renally adjusted. And of course, there's also a dosing for the obese, okay, for BMI more than 40. With mechanical thromboprophylaxis, in a recently pooled analysis of mechanical methods employed as monotherapy for VTE prevention, it reduces DVT by 66%, but it's insignificant reduction of 31% in the frequency of your forward development of pulmonary embolism. So the combined prophylaxis, according to Lehman and Corona, that low-dose unfractionated heparin combined with graduated compression stocking is 4 times more effective for VTE prevention than low-dose unfractionated alone. When we talk about extended prophylaxis, can we give this extended prophylaxis? This is the slide should be more than 6 months of giving it, no? But all these drugs can be given in the same way. So these are some of the types of procedures that will help us determine if this patient is high risk for bleeding or our patient is high risk for bleeding. So under the very high risk, you have neurosurgical, you have urologic, and cardiac surgery. That tells us that this patient will have a likelihood of bleeding tendency. That's why thromboprophylaxis may or may not be offered for this patient, or be very careful in offering this. Second, our patient, on the other hand, is a major intra-abdominal surgery that is high risk for bleeding. No? So these are some of the contraindications for VTE prophylaxis. Active bleeding, definitely you won't give it. Thrombocytopenia of less than 50,000 or clinical judgment. But according to the International Society of Thrombosis and Hemostasis, for patients who have platelet counts of more than 50,000, they recommended giving the therapeutic dose of VTE therapy, no, your low molecular weight heparin. But less than 25, of course, you have to stop. It is recommended to stop. But in between 25 to 50, you can reduce it to a therapy by 50% of the therapeutic dose. Ina?
So, Dr. Akaiton, is it safe to start our patient with VTE prophylaxis prior to
start
surgery?
our patient with VTE prophylaxis prior to surgery? So our answer is yes.
So prophylaxis should be commenced pre-operatively or as early as possible in the post-operative period. So prophylaxis should be continued for at least 7 to 10 days post-operatively, and prolonged prophylaxis for up to 4 weeks may be considered in patients undergoing major abdominal or pelvic surgery for cancer with high-risk features such as residual malignant disease after operation of these patients and those with a previous history of VTE. Ina?
So what are the other considerations for our patient? Anemia. So anemia is very common in cancer patients. Okay? It occurs in 10 to 50% of patients in the pre-operative setting and as much as 90% of patients in the post-operative setting. It is considered an independent risk factor for mortality and morbidity and slows down recovery. It can prolong hospital stay and can diminish the quality of life. So, preoperative anemia is the most frequent predictor of perioperative transmission. Blood products have become scarce, and the decision to make can use of it should be done after all measures to conserve blood has been done, because it poses risk of sepsis as well as pulmonary thromboembolic events and wound complications. The treatment of anemia in cancer patients is more challenging than simply transfusing blood products. The combination of surgery-induced and anesthetic contributed immunosuppression may further be aggravated by giving blood products that have inflammatory and immunosuppressive effects, which can also be explained by TRIM. TRIM is transfusion-related immunomodulation. It is an important complex biological immune reaction to transfusion that culminates in immunosuppression. Okay. How does blood transfusion promote cancer recurrence and dissemination? The presence of residual leukocytes and apoptotic cells, the inflammatory mediators, and the microparticles present in the allogenic blood will cause the immune reaction that will trigger transfusion-related immunomodulation and the expression of pro-inflammatory and immunosuppressive particles that can lead to cancer growth and dissemination. A couple of studies has been made in different cancer types to show that transfusion has a negative impact on patients. One of the studies done by Abu Ghanem on patients with renal cell carcinoma, which showed that perioperative blood transfusion is associated with an increased cancer recurrence, cancer-specific mortality, and overall morbidity. A meta-analysis done by Boshier et al. On patients undergoing esophagectomy for esophageal cancer showed that allogenic blood transfusion and long-term survival after esophagectomy for cancer patients confirmed worse outcome in those who received blood in the perioperative period. Another study done by Zhang et al. On patients with ovarian cancer showed that perioperative blood transfusion was significantly associated with more in systemic inflammatory indicators, a prolonged length of stay in the hospital, higher post-operative complication rates, and an increased cancer recurrence and overall mortality. Another study done with patients with non-small cell lung cancer showed that a dose-response relationship was observed, demonstrating an increased recurrence rates and decreasing survival in escalating RBC transfusion.
Short, we have to adopt a concept of patient blood management. This is an interdisciplinary blood conservative methods that optimizes coagulation, manages preoperative anemia, thereby improving patient outcomes. So by patient blood management to improve the red cell mass, we usually give your hematinics together with your erythropoietic agents, minimizing blood loss by surgical techniques or giving your tranexamic acid or blood salvage, harnessing and optimizing the tolerance of anemia and restrictive transfusion threshold. So these are the practice guidelines of perioperative blood management according to the American Society of Anesthesiologists. The first and foremost that we do is patient evaluation prior to going to the procedure. So that's very important. It's very basic. So the previous medical records of this patient, if the patient has previous transfusion, review of all the medications. We need to review the family history for congenital anemias, or second, if either bleeding tendencies, reviewing the existing labs, or that's why we need to review the existing labs at the same time, because if we need to have additional labs as necessary. Okay? So in patients' preparation, these are the treatment of possible anemia. So we treat for renal insufficiency. We may give your erythropoietin, or in anemia of chronic disease, the combination of your erythropoietin plus your iron may be given. Discontinue your anticoagulants to prevent exacerbated bleeding and autologous blood collection if erythropoietic reconstitution permits it prior to the surgery. So, in short, in the evaluation of anemia, the patient, we say that the patient is anemia based on the WHO category. If it is less than 13 for males and less than 12 for females and less than 11.5 for those who are pregnant. So if we see that the patient is anemic, then we have to work out for iron deficiency or iron deficiency anemia, because this is the most common cause of anemia, iron deficiency. So we request for the laboratories of testing for transferrin saturation. Now the question is, why are we not testing for serum ferritin? We can test for serum ferritin, but of course, remembering that serum ferritin, just like your CRP, your ESR, are inflammatory agents. They tend to increase in the states of inflammation or infection. With cancer in mind, cancer is a persistent inflammatory state. So you expect that your serum ferritin levels are already elevated and may not be a good picture to determine iron deficiency. However, the transferrin saturation does not. That's why we compute for the transferrin saturation by dividing your serum iron with over your TITC. Now, if it is the key number would be 20%, if the transferrin saturation is less than 20%, then it's consistent with iron deficiency. And of course, you know how to treat iron deficiency. So we just give your iron supplementation. Now, which is faster, your oral or your iron, or oral iron or your IV iron? Of course, your IV iron will have a good bioavailability, 100% bioavailability. Now, in case your transferrin saturation is more than 20%, probably you need to evaluate other organ systems that may be contributing to the anemia. Primarily your renal, which if in cases of renal insufficiency, there is erythropoietin, it is erythropoietin deficient. You may want to give your erythropoietin to induce RBC production. In cases of alcoholics, which might damage the liver, your folic or your B12 may be depleted, you can just supplement. But placing in mind that when you want to schedule a patient, give us 4 weeks. Give the team 4 weeks prior to scheduling the patient to surgery. Okay? So these are some of the advantages and disadvantages of your oral iron. As meant, oral iron, IV iron, and blood transfusion. So the advantage of oral iron would be your cost. Non-invasive, it's simple administration. Of course, you have to be, the disadvantage should be some of the patients, or most of 50% of the patients will develop GI upset. They always complain of that. They complain of constipation. Some patients complain of diarrhea. That's causing your poor tolerance, poor compliance, and of course, a slower increase in your hemoglobin. With regards to your IV iron, you have a high iron content, as mentioned earlier, 100% bioavailability. It's fast-acting, well-tolerated. However, it has a potential for adverse events. This is in particular for IV dextran. No? So IV dextran can cause anaphylaxis, but I think it's been withdrawn from most hospitals and it's no longer seen. So for the younger generation, IV dextran can cause anaphylaxis. Caveat to that is that before inducing your or giving your IV dextran, you have to do cross matching already. Remembering that IV dextran is a carbohydrate, no? That can spell out a difference between your blood typing. They might get confused for that, no? So blood transfusion, on the other hand, becomes only essential for in cases of cardiovascular instability. It replaces your RBCs immediately and compliance. However, you have to be careful of the potential transfusion reactions. It is invasive, it is costly, and it has a limited and compromised supply. So what about your erythropoietin? Your erythropoietin agents can be given for anemia and inflammation, particularly in these cases of oncologic problems. No? These are the dose that can be given. So we still have to wait for 4 to 6 weeks before we see a response for this patient. So going back to you, Ina.
Intraoperatively, as anesthesiologists, we can do re-inclusion of recovered RBC. We continue patient monitoring, so we quantify our blood loss by looking at the operative field and the suction. We monitor perfusion of organs by monitoring your urine output, and you can also get your mixed venous saturation. Monitor anemia and coagulopathy using your blood extraction for hemoglobin hematocrit and your PTA-PP and INR. And you monitor if you decide to transfuse blood to monitor the adverse effects of blood. So intraoperative treatment of excessive bleeding is by the use of desmopressin. And we also encourage surgical hemostasis. Okay? They can use topical hemostatics such as thrombin gel and fibrin fluid. So a systematic review and a meta-analysis was done, which showed that anti-fibrinolytics are very useful in intraoperatively to decrease bleeding. The use of tranexamic acid at a dose of 20 milligrams per kilogram before the start of surgery is very effective in decreasing your blood, to decrease your bleeding, and the use of epsilon aminosuccinic acid. After everything has been done and there's a cardiovascular compromise, and we decide to transfuse, we choose the restricted transfusion strategy and should always be guided by the potential for ongoing bleeding, intravascular volume status, signs of organ ischemia, and adequacy of cardiopulmonary research. Post-operative management should increase close monitoring for bleeding. The most common cause of post-operative anemia is exacerbation of pre-existing anemia, excessive post-operative lung exams and phlebotomies, and reduced iron stores. If post-operatively the patient still needs transfusion, we should use the restrictive transfusion regimen. In
summary, we propose this patient blood management program that covers both your the perioperative process. The first pillar is really to optimize the red cell mass. No, this is to detect anemia, check for the underlying cause, and treat it probably. If you're going to see the note here, preoperatively, anemia is a contraindication for elective surgery. The second pillar is to minimize the blood loss, identify and manage the bleeding risk, procedural planning and rehearsal, and minimizing iatrogenic blood loss. The third pillar would be to harness and optimize physiologic tolerance of anemia, that is to assess optimized patients, compare estimated blood loss with that of the patient's-specific tolerable blood loss. So in our patient, after anemia screening, the patient is the hemoglobin is 98, the hematocrit is 28. The transferrin saturation, as you can see, is 14. So this is less than the key number of 20. We are considering iron deficiency in this case, despite the fact that the ferritin levels is at 231. So we decided to give this patient parenteral iron sucrose.
Going back to our patient, we decided to give pre-operative iron sucrose, and intraoperatively give tranexamic acid, minimize blood loss and surgical control of bleeding, and post-operatively continue monitoring bleeding and proper management of anemia.
In summary, anemia should be screened properly, diagnosed, and properly treated. Second, transfusion is not a default treatment. Third, perioperative blood loss should be minimized. And fourth, The monitoring doesn't end post surgically, no? So treatments of anemia should be done also post-operatively. We should still monitor post-operatively. Thank you very much.
Thank you very much.
Thank you very much, doctors. That is a very enlightening and exciting panel discussion. We would like to proceed with the question and answers. We have a few questions already in the chat box. If you have any more questions, just feel free to type it in the chat box while our speakers are still with us. For our first question, which is better in preventing VTE, intermittent pneumatic compression or anti-embolism stockings? Who would want to answer?
Okay. Both are considered your mechanical thromboprophylaxis. Both are only more effective if combined with your pharmacologic therapies. So, for patients who are not ambulatory, who are at risk for thromboembolism and to be immobile in this, I think it's best if you can give either compression stock, either the intermittent pneumatic compression or the compression stocking in combination with your pharmacologic therapy.
Okay. Thank you, Dr. Kaitan. We have another question. In a low-income setup where cell savers or non-urologic or non-cardiac surgeries are there still other hemostatic medications we can give? Cell
You can
cell savers,
cell
and
save
if
used in actually in ideal setup, you can have your cell savers, but in our setup, I think tranexamic acid, giving it at 20 milligrams per kilo, can decrease your blood loss by about 300 to 500 ml. So giving it before your surgical cutting will be more effective. I'm saying 20 milligrams per kilo because giving it at a higher dose doesn't increase its benefits, but um, may give the side effects to the patient. So 20 milligrams or 10 milligrams per kilo and 10 milligrams per infusion is enough to help decrease your blood loss intraoperatively.
so for tranexamic acid, you're saying 20 milligrams or 10 milligrams per kilogram. How
Kilo
how
dose,
close to
sorry.
per kilogram? How close to the scheduled operation would you like? You said prior to the operation. How close to the scheduled operation would it be best to be
You can
given?
give it bolus, slowly, because it can cause hypotension if you give it fast. You can give it before cutting. Even intraoperatively after induction, you can give it before cutting.
And do we continue this up to post-op?
Studies show that continuing it post-op is not really that beneficial to control your blood loss post-operatively. So intra-op bolus of 20 milligram per kilo is enough to control your breathing intra-op.
Okay. Thank you, Dr. Kaitan. For Dr. Jomel Julian, how do you give the IV iron? What's the dose and how many days before the scheduled
Actually,
procedure?
there are different what do you call this? There are different preparations for IV iron, no? But we have to use your Ganzoni equation to compute for your iron deficiency.
Oh,
It can be Googled, don't worry. You don't have to memorize the Ganzoni formula. It can be Googled, but there are different preparations, your iron sucrose, your ferric gluconate, your ferro moxitol, and at the same time, what's available here is your ferric carboxymaltose. So the dosage for each would be different. The maximum dose for iron sucrose for the day is at least 200 milligrams. No, for ferric gluconate is 125 milligrams. It can be infused around for iron sucrose, which is more common or readily available here. It is very inexpensive. It can be given in a 15-minute infusion or it can be given in 2 hours. The only problem, we can give it every other day, no? Every other day. Uh, However, the downside to this is that you have to watch out for the possibility of an allergic reaction. That's the only thing.
Okay. Okay.
Thanks, Rox.
Thank you, Doctor. Another question for Dr. Huyan. Which is better for anemic cancer patients, alpha or beta epoetin? Since the patient has
Uh,
epigastric pain
Actually,
in
there are no
ferrous.
data yet available distinguishing between alpha and beta the type of erythropoietin. But ang tawag dito, sorry. There's no data for that, but we can use either of the two, no? Depending on the dose, increasing the dosage for these patients. No? You just increase the dose if the patients, if it's not working for the first 4 weeks or first 6 weeks. So we can only see response to erythropoietin in the next 3 or 4 weeks for these patients. So after that, you can shift or you can increase the dose. That's the technique for that. But distinguishing between alpha and beta type of erythropoietin, there's no adequate literature to favor one from the other.
Okay. Thank you, Doctor. Another one for any speaker. What is the internationally recognized level of blood hemoglobin where blood transfusion is indicated? And follow-up question, for cancer patients, do we follow the same is it, do they have a specific criteria with it with terms of the limit, the minimum hemoglobin or hematocrit for surgery? What are the challenges in caring for a child for cancer surgery? Our guest speaker is a psychologist from Cebu. She had her PhD at the LaSalle University for clinical psychology and has her master's in family life and child development at the University of the Philippines. She is a member of the Psychological Association of the Philippines, as well as the Association of Child Life Professionals in the United States. She was recognized in 2020 as one of the first cohort of 40 women social entrepreneurs and was a Bravo awardee of 2021 in the field of social services. Colleagues, it is my pleasure to introduce Dr. Angelita Rosario Sievert Fernandez. Dr. Fernandez?
Good afternoon, everybody, and thank you for having me here today. It's a pleasure for me to share with you what I know and what I've learned over the years in supporting children with cancer through their healthcare experiences. So please allow me to share my screen. Today we'll be talking about challenges in caring for a child with cancer surgery. And in this conversation, we'll go through very briefly about a child with cancer, understanding children at different stages. I think this is very essential for us to know what to do. We have to understand who we're doing it to and who we're doing it for. And then strategies to help children who will undergo surgery. This is generally how we view kids and how we want kids to really be happy, eating ice cream, being in the playground, and even during pandemic time, just playing and being with siblings and relatives, enjoying going to the beach. However, this is also faces to our children, and these are faces that we, most of us, in this talk this afternoon, may have to deal with. Children with cancer, children whose lives are turned around by the diagnosis of chronic illness. So imagine a child who's with his or her family, having fun, growing up, playing, going to school, and then he or she starts getting sick, and then after some tests is diagnosed with cancer. Imagine the pricks and the pokes, the changes in the routine, the medical procedures, treatment that the child needs to undergo. Imagine the fear, the anxiety that these children are experiencing. It's not easy. Support for our health, for their healthcare experiences is very vital. There's a lot of literature telling us about the effects of chronic illness on a child, and the effects of their healthcare experiences are not only now at the time of care, but it can even impact many years down the road. Some of the studies have said there's now substantial body of research affirming that children who have been repeatedly exposed to anxiety-provoking painful medical events are at increased risk for developing adult dysfunctional cognitions and avoidant attitudes towards healthcare. Furthermore, frequent or prolonged hospitalization may negatively impact on children's psychological well-being and increase the risk for long-term emotional and behavioral difficulties. What then can we do? The next slides will focus on knowing and understanding the child, the value of preparation and education prior to surgery or prior to any medical procedure for that matter, the use of language that conveys hope and support. You know, it seems very simple, but there's a huge difference that can be made in making an environment a safe place for our children just by the use of language, what to say, what not to say, how to say it. We'll touch a little bit on that one. And finally, when needed, the use of non pharmacological pain management strategies to supplement the pharmacological pain management strategies that are being used. So let's start with understanding our children. And what we'll do is we'll go through the different stages neonates and infants, toddler, preschool, school age, and adolescents. And then we'll briefly touch on hospital-related developmental characteristics, and then what might be characteristics when these children are in pain. So neonate and infants are the littlest ones from 0 to 12 months old, and you will notice that one of the main hospital-related developmental issues would really be separation from their primary caregivers and the disruption of routines, because these two are the ones that make a neonate and an infant feel secure, feel safe, and makes the environment predictable. And when a child is diagnosed with a serious illness, often they're separated from their primary caregivers, and the disruption of routines, because what they've been used to changes. There are also strange sights, sounds, and smells that weren't there before, and loss of normal stimulation that generally occurs when they are in their home setting. And a very vital issue that needs to be looked into is the parent's fear or anxiety of the medical environment. The literature will tell us that a parent's feelings of anxiety will transfer onto their children. So it's important to also support the parents. Now, when an infant or a neonate is in pain, they are unable to really express it verbally, so we rely on behavioral observations. And these include changes in facial expression, sleep and wake cycles, and also changes in the indices of heart rate and oxygen saturation. When we go to toddlers, anybody between a year to 3 years old, still separation from their primary caregivers are issues, and contact with unfamiliar people. Um, Similar to the younger ones, which starts around 6 months to 2.5 years old, separation and anxiety, toddlers also prefer to be with their primary caregivers and often cry and feel unsafe when there are others who want to care for them and they're not familiar with. There's also restricted movement. Remember that they're beginning to walk, they're beginning to run, they're beginning to explore and climb. And when they're in the hospital setting confined, these are restricted. And fears start also fear of the dark or loud noises. And these are things we look out for when we're working with toddlers. When a toddler is in pain, one of the important things that we have to be aware of is the word that they use to express their pain. Do they say owie, ouchie, yay yay, na? What is it? So that when we hear that word, we know what they're trying to say. When a toddler is in pain, it can also go two ways. It can either be they become quiet, inactive, or they become very active. So that's part of the misconceptions of children's pain, really, now that when a child is active, a child is not in pain. But then again, the literature will tell us that that is a misconception. Um, they're limited in their cognitive abilities to express what kind of pain and where that pain is. And parents report that they aren't acting like they normally do. And I remember this conversation I had with a mom. Her daughter was 3 years old and she's showing me a video saying, oh, Dok, tingnan niyo po, oh, kumakanta po siya talaga at sumasayaw po siya talaga. Pero, ngayon, hindi na po, natatakot po siya, tapos tahimik lang po siya. And true enough, the child wouldn't really respond to. So changes in behavior also often occur. The face is still is a tool that can be effective for that um, stage of children. Then we have the preschool child. The literature will tell us that among the ages or stages of children in the healthcare setting, the preschool children are the ones most vulnerable. They're the ones prone to misconception. And that is also because of cognitive development. At this stage, from 3 to around 6 years old, there's what we call magical thinking. And in magical thinking, the cause and the effect don't jive. So it's like when parents fight and the child didn't eat vegetables this morning, the child will think, kaya nag-aaway si mama at si papa kaya hindi ako kumain ng gulay kanina. Or when the parent will say, hala, sige ka, ang kulit-kulit mo, i-injectionan ka. They will actually believe that they are getting injections, they're getting this treatment as punishment for their behavior. So it's how we talk to children at this age is extremely We have to be extremely cautious and mindful about how we talk to them. There's also fear of needles and shots and unknown events and mutilations. They think body parts will get hurt or will be taken out. No? And again, this is part of magical thinking. There's lots of newly acquired skills. So these are the kids who are able to mostly eat on their own, they're toilet trained, they can change, but because of anxiety, fear, or stress, sometimes it impacts on um, the skills and regression can happen. And then there's lack of stimulation also. A preschool child in pain has more words to describe his pain or where it might be located on his experiences as a whole. However, as I said earlier, it might lead them to think, magical thinking might lead them to think that they are being punished. That's why they feel pain. That's why there are procedures. There's still changes in behavior that may occur, and a tool that can be effective for this age is the PACES scale. For school age, this is anywhere between 7 to 11 years old. One of the distinct characteristics of school age children is their desire to be acknowledged for what they can do. Because when in preschool, children are learning the basics of reading, writing, all those other things, no? Math skills, for example, drawing. When they're in school age, they're mastering these skills. And so they want the acknowledgement, they like showing us what they can do. And when a cancer diagnosis comes into place, many things can come in the way of the mastery of these skills or the expression of these. And so there's loss of control and there's loss of confidence. They're hesitant to say something about what's going on with them and how they feel. They don't want to become like kids again, that they're very dependent. They want to show that they can do things on their own. These are some of the issues that may be evident in a school age child. There's also fear of pain and the anticipation of pain and invasion of privacy. A school age child in pain has increased ability not to tell us about their pain, can reliably describe pain. And I remember working with, I think he was around 8 or 9 years old, this child with cancer. No? And when I was talking to him about procedures and stuff like that, he said, yung BMA po, parang binabarena. Nakikita niyo po yung mga tao dun sa daan, yung nagkukumpuni ng daan, tapos meron silang grrrr, ganyan. Ganyan po ang BMA, binabarena. They use words like kumikilam, so they can identify it. So it's vital to, for any age for that matter, to take care of pain seriously. We should also be aware that sometimes they may pretend that they're not in pain, they may pretend that they're okay because they don't want that impulse to test them as pain. And then a tool that can be effective would be body outline, faces scale, and the visual analog. And finally, our adolescents. Remember that these adolescents, they're in between being children and being adults. What is important for them is independence. What is important to them is being heard. Also, what is important to them is body image, how they are perceived by others. And so at this stage, in hospital-related characteristics, helplessness is mostly affected or visible, and they're concerned with body image. I remember working with a 13-year-old girl, just a majorette in the province of Cavite. Kasi siya yung nasa harap magbabaton, whirl ng baton when there would be parades, no? And she was diagnosed with cancer, underwent treatment. Her mother decided that her hair should be shaved. And then due to the medication and treatment, lumaki yung mukha niya, nagkaroon siya ng itchies and all of that. And that was a huge effect on her, and impact on her. She became sullen, she became depressed, she wouldn't interact. In fact, would have violent outbursts when bored. So there's also loss of peer acceptance because peer groups are very important at this age. Fear of surgery and its risks, this is the age, and fear of anesthesia. The literature will tell us this also, and I have come across some teams, no, really verbalize this. I worked with him. He was a 17-year-old boy. He had hemangioma, and he was going to have surgery. So I prepared him prior to the surgery. And when we were discussing, one of the things that he said was, natatakot po ako, baka magising po ako habang inooperahan ako. Maramdaman ko yung sakit. So at this age, very important to actually explain to them the role of anesthesia, how much anesthesia is given, so they're not wake up within the procedure. And there's denial of their illness, which may impact on compliance. That means some of them will actually throw away medication or not take the medication if they can get away with it. This can be an occurrence. An adolescent in pain will definitely be able to verbalize and appropriately describe, no, the pain, the intensity, and the medication they're taking. And what is something to look into here is the sense of being in control. Remember that it's helplessness more than illness that is a concern to them. So you need to elicit their trust. That's very important to maintain and listening by ensuring that they're part of the treatment planning that has to be made for them. Okay, so that's understanding our children. And if we have that, the next thing, very important, would be preparation and education. If you look into the literature of what helps our children adjust to the healthcare setting, to the healthcare experiences that they're having, and ensuring that there are no long-term psychological sequelae, you will find that it's play, preparation and education, emotional support, and parental involvement. These four, if these four are in place, we are supporting our children the best way we can and hopefully buffer long-term psychological sequelae. What is preparation? It is the process of, and this one is important, communicating accurate and developmentally appropriate information, identifying potential stressors, as well as planning and practicing coping strategies. That means we actually talk to them about what's going to happen in developmentally appropriate terms and within the bounds of what they're ready for and what they want to know. I was playing with this 8-year-old in the ward one time, and then in the course of our conversation, I asked her, pag ba may gagawin na procedure, gusto mo bang malaman or hindi? Tapos ang sabi niya sa akin, sabi po ng mama ko, dapat daw hindi sasabihin sa akin kasi natatakot ako. Pero para sa akin, gusto ko pong malaman. Kasi po katawan ko yan at alam ko, gusto kong malaman kung anong mangyayari. That's how important preparation is. It actually lowers anxiety and stress the same way we as adults want to know what's going to happen. No? So how do we do this? We do this in different ways. And how can, before I get into how we do it, what can preparation and education do for our children? It helps make the predictable events more manageable. It provides opportunities to work through their feelings and fears. It's very important. And it enables the child to plan and rehearse coping strategies. We want them to be empowered. When they're feeling in distress, when they're feeling anxious, hopefully we're able to help them come up with strategies to calm themselves. These are some books that we use, in preparing children for surgery, in preparing children for various medical procedures. I remember the 17-year-old girl, Nona, she had a growth on her thigh and she had a good prognosis. It was to be taken out. I think she was to undergo chemo after the surgery. And she did the surgery and she did a round of chemo and just referred to me because she didn't want to continue with the treatment anymore. And in my interactions with her, what came out was prior to the surgery and get going through the surgery, she was so scared, she was so anxious because nobody really explained to her what was going to happen. She relied on Google. And she was so very scared that being wheeled into the OR, she was crying. And the nurse, who I'm pretty sure just really wanted to help and calm her, said, huwag ka na umiyak. Mabilis lang yan, tapos matatapos din yan. Huwag ka na umiyak. And that wasn't very comforting, even when the nurse wanted to relieve her of it. And she told me, ayoko na po makaramdam ng ganong klaseng takot. Ayoko na po gawin. And that made me really sad, no? Because preparation, education, and emotional support could have been a huge help. So these are other toys, no, and things that we use pre-pandemic. And we use this pre-pandemic, but these books are now in soft copies, and we're still able to use them during these times. So a psychological preparation involves establishing trust. Very important that the patient trusts you, is comfortable with you, knows that his mama trusts you too. Information about the procedure that's developmentally appropriate includes sensory information. What do you see? What will you see from here to there? Part of the preparation that I do is showing them how an OR might look like, who might be there, what might be there, who will be there when I wake up. Okay, how might it feel there? Explain the sequence of events and again emphasize coping strategies. So these are when to prepare our children. Toddler, just the day before, we don't want too long, okay, because that's going to make them anxious. Preschool, 3 days before the procedure, school age, a week, and the adolescent, we want to begin at the soonest time we're able to tell them that this is going to happen, the surgery is going to happen. We want them involved in the planning. Language that conveys hope and support. Here are some, you know, I guess reminders or strategies on how to use language that conveys support and hope. Use honest and simple language. No metaphors as much as possible. No euphemisms, but really just direct. Respond promptly to a child's distress in a caring and practical manner. And how do we do that? Acknowledging it. When a child is sad, we don't have to say, ay, wag ka na masad, okay lang, bili ka lollipop mamaya. O hindi naman yan masakit. Pero kasi masakit eh. Pero kasi nakakatakot eh. We can actually do more for the child when we acknowledge it and say, nakakatakot talaga, no? Minsan di natin alam, no, kung ano nangyayari. Sad ka talaga. You're angry. Acknowledging that emotion is more powerful for the child than just saying, no, huwag ka magalit. Madali lang yan. Praise the child for doing their best. When we do praise, often the praise that I hear would be good job or very good, and that's good praise, better than nothing at all. But if you want praise that's effective, if you want praise to work, make it specific. So I will say something like, natutuwa naman ako na uupo ka dyan ng maayos habang nag-check ako. Uy, nakita ko, nag-breathing kang ganyan kanina habang kinukunan ka ng dugo. You be very specific to the behavior that you see. Then the child knows what he or she did wrong. Inform the child about what's happening to his or her body. Instruct the child to do something that will help calm him down. So that's where coping strategies come into place. And if possible, healthcare experiences can be really frightening for children. And if it's possible, allow someone to remain for the child. Older individuals like adolescents may want to be on their own, and that's okay. And tell the child what positive steps are being taken or will be taken in caring for you. And finally, when applicable, the use of non-pharmacological pain management strategies. These are divided into cognitive, behavioral, physical, and psychological therapies. When we talk about cognitive strategies, it would use thinking and imagining. When it's behavioral, it has to do with the control of bodily sensations. And physical would be the surroundings. Psychological therapies will pertain more to the use of CBT or anxiety, acceptance and commitment therapy, generally done by psychologists, but I'll put it in there for information purposes anyway. These are some techniques, cognitive techniques. There's distraction, there's imagery, the use of the imagination, there's education and preparation that we talked about, some apps and videos, and coping statements. Now, I cannot get into detail for lack of time, hopefully at another time, but these are some cognitive techniques that can be used. Behavioral techniques, modeling, coping, positive coping strategies, very important. If the children actually see how we do it, the parent, there's also parent coaching there. Now that means we need to teach our parents how to do it. And then they can model it, we can model it, and our children will pick up on that. There's positive reinforcement. When they do something good, we say something to acknowledge that. We reinforce the behavior that was correct, that we like. And then there are breathing and relaxation strategies. Why do we include parents? How parents feel and what they think and do influences their child's perception of distress. Parents need to be included in pain management interventions. And there are physical techniques, calm environment, massage, touch, and physical therapy, and heat and cold packs. And one thing about calm environment is what you call one voice. That means when you are in an environment where there are different people, like the parents are there, the doctor is there, the nurse is there, and the child is there, as much as possible, let the child hear only one voice so that it actually impacts on the calmness, no? And how the environment impacts our children. And these are the psychological therapies that I mentioned earlier. Okay, so we remember that we have to know and understand our children. Preparation and education is essential. Use language that conveys hope and support, and use of non pharmacological pain management strategies when applicable. I end this talk this afternoon with this. Unless someone like you cares a whole lot for life, nothing is going to get better. No, it's not. And I know that we can do lots for our children in making their healthcare experiences better. So, thank you very much for your kind attention. Thank you.
Thank you very much, Dr. Shevert Fernandez. Thank you for your very comprehensive talk and for a very sweet, um, comprehensive talk regarding caring for children with cancer. We would like to award a certificate of appreciation to Angelita Sivert Fernandez, PhD, for sharing her knowledge as honorary speaker for the Dr. Nerissa Santos Honorary Lecture on Pediatric Anesthesia during our 13th postgraduate course in anesthesiology, signed by Dr. Marquez, Dr. Madarang, Dr. Soliven, and Dr. Rantil. Thank you again, Dr. Fernandez. For the next series of lectures, we will focus on unique cancer procedures that may pose challenges to anesthetic management. So after this, you may type your questions in the Q&A box for our open forum after this series. Let us explore the depths of anesthesia in patients for these unique and challenging cancer procedures. Our next speaker is a fellow anesthesiologist who had his residency training at the UST hospital and his clinical fellowship in surgical intensive care at the National University Hospital, Singapore. He is currently an active medical staff member at St. Luke's Medical Center Global City and UST Hospital. He is a mainstay lecturer in all our previous national conventions, and he constantly shares his expertise and up-to-date knowledge to us. He is my RTO during residency. Colleagues, let us welcome Dr. Ruben Policarpio.
Good afternoon. Our talk for this afternoon would be on anesthetic considerations for laryngeal cancer patients. Laryngeal cancer is the second most common malignancy of the respiratory tract. Worldwide, there are over 180,000 new cases in 2020, with almost 100,000 deaths in the same year. In the Philippines, this is the 20th most common malignancy. Philippine data shows 1,500 new cases for that same year with 1,000 deaths. It may not be as common as the other types of malignancies, but there are specific anesthetic-related issues that may have a significant impact on practice. The objectives of this talk are the following. We will discuss the anesthetic considerations in laryngeal cancer surgery, highlight important aspects of preoperative evaluation, where we will talk about the concerns specific to these patients, like a potentially difficult airway, the concept of a shared airway, the effect of adjunct treatments like radiotherapy on these patients, and of course, we will discuss the different airway and ventilation management strategies. Surgery in the larynx poses a unique challenge because the surgeon and the anesthesiologist work in a shared surgical field. The need for an unobstructed, motionless view and unimpeded surgical access must be balanced with a safe method of oxygenation, ventilation, and airway protection. An important part of a thorough preoperative evaluation includes an anesthesia-directed assessment that focuses on the following: airway exam, ancillary procedures for imaging. We check for the history of radiation treatment, all with the purpose of trying to recognize a potentially difficult airway. Some signs and symptoms of obstruction that we should check are the following: dyspnea, changes in voice quality, stridor, although its absence doesn't rule out a significantly narrowed airway. The rate of difficult intubation for these patients is 4 times higher than the general surgical population. The standard tools we use in pre-op airway assessment, like malampati, thyromental distance, interincisor distance, may fail to consider certain lower airway problems, tongue-based pathologies, hypopharyngeal stenosis, which may not be easily appreciated. This underscores the importance of reviewing imaging studies like CT and MRI. Ultrasound also is emerging as a valuable tool that can be used to screen for difficult laryngoscopy. It may help us assess the size of the airway, choose the correct endotracheal tube, confirm its placement. It also helps in identifying the cricothyroid membrane for emergency front of neck access or for prophylactic placement of a cricothyroid cannula. Pre-op nasoendoscopy is the gold standard for dynamic assessment of the airway. It tells us whether it's safe to secure the airway with awake fiber optic intubations or to proceed with an awake tracheostomy. In some cases, normal findings may tell us to avoid unnecessary fiber optic intubations and awake tracheostomy since they are not without complications. Some caveats, however, it is not predictive of how the airway will react once these patients are under anesthesia, and it also doesn't correlate with the ability to ventilate or the ease of laryngoscopy and intubation. One of the things we check in the pre-op assessment is a history of radiation treatment to the neck. This may lead to radiation fibrosis with tissue scarring leading to limited mouth opening or cervical spine motion. Hypopharyngeal stenosis have been observed. Patients may have a fixed tongue, non-compliant, immobile, soft tissues of the mouth, and tissues inside may become edematous and friable, all leading to possibility of difficult mask ventilation, difficult laryngoscopy, and even difficult intubation. This is a case of hypopharyngeal stenosis that resembled an edematous larynx. There was even an anterior superior tissue flap that resembled the epiglottis and a centrally located aperture that could have easily been mistaken for the glottic opening. In this case, this is a case of recurrent laryngeal cancer post-radiotherapy. The patient didn't have any stridor, the breathing pattern was unobstructed, but despite this, they attempted to do an awake fiber optic intubation, which failed, and the patient had to undergo an emergency tracheotomy. Those patients with a full course radiotherapy or bilateral neck radiation may be at risk for baroreflex dysfunction. The exact statistics on its incidence are unknown. Episodes of orthostatic hypotension is suggestive of this, and most are asymptomatic, but these patients may exhibit labile hemodynamics once they are under anesthesia. An ideal anesthetic for laryngeal surgery is one that provides a secure airway, adequate oxygenation ventilation, motionless surgical field, and low risk for combustion. Some important questions we have to ask ourselves when managing these airways is, will it be difficult to pre-oxygenate and mask ventilate these patients? Will laryngoscopy and intubation be difficult? Are awake techniques safer? Is emergency surgical or front of neck access feasible? IV induction is suitable for majority of early malignant glottic lesions without airway obstruction. Muscle relaxants are needed for a motionless surgical field. On the role of inhalation induction for obstructed airways, there's a traditional belief that states that inhalation techniques are safe because if encountered difficulties in the anesthetics are turned off, the patients awaken. This view has been challenged by some airway experts who claim that inhalation induction for advanced tumors is difficult, slow, challenging, and often fails. Physiologic problems associated with it include reduction in airflow with spontaneous ventilation. There is increased collapsibility of the airway with increased work of breathing. Episodes of airway obstruction are common. Patients may become hypoxic and hypercarbic. And patients usually don't wake up rapidly. The fourth national audit project of the Royal College of Anesthetists and the Difficult Airway Society came up with a one-year registry of major airway complications during anesthesia and in the emergency department. 40% of anesthesia cases involved head and neck surgeries, and this reported 16 patients with head and neck pathologies who had inhalation induction. Of these 16, 12 encountered difficulty with spontaneous ventilation, airway obstruction, and oxygen desaturation occurred. In 11 patients, spontaneous ventilation became impossible, and despite the respiratory distress, the airway obstruction, and hypoxemia, and with the anesthetics turned off, these patients did not rapidly awaken. The NAP4 audit concluded that inhalation induction in this setting can and does fail when this technique is used, and that there should be a clear rescue plan that does not assume that the patient will awaken. The management of the airway and ventilation in these cases can be classified into two broad types. On one hand, you have closed or intubated techniques, and on the other hand, you have open, non-intubated techniques. Closed techniques or closed systems are familiar to all of us. This involves the usual conduct of anesthesia with pre-oxygenation and IV induction, plus muscle relaxants and intubation with a cuff tube. This allows positive pressure ventilation and protects against aspiration. However, the presence of tracheal tubes limits surgical visibility, may interfere with surgical manipulation, and may put the patient at risk for airway fire. Open systems or non-intubated techniques provide the best laryngeal view. Ventilation is achieved through apneic intermittent ventilation, supraglottic, subglottic, or transtracheal jet ventilation, or insufflation or spontaneous ventilation techniques. First is apneic intermittent ventilation. This involves intermittent removal and replacement of the endotracheal tube by the surgeon through the operating laryngoscope. This provides an unobstructed view of the larynx. Disadvantages include frequent interruptions, the risk for laryngospasm, and lack of airway protection. Now, jet ventilation techniques use high-pressure source ventilation through narrow-bore catheters. These can be delivered via supraglottic or subglottic or transtracheal routes. Early low-frequency jet ventilation techniques use the Sanders injector. This provides low-frequency jetting of around 8 to 10 per minute of oxygen through a narrow-bore catheter. A newer system like the ManuJet has been used similarly. This allows for better control of inspiratory pressures compared to the older Sanders injector. Modern jet ventilators use high-frequency jet ventilation with rates of up to 100 to 150 per minute. They use narrow catheters like the Hunsaker Monjet catheter, which is less space occupying and is made up of non-flammable material. They are double lumen cannulas. One is for gas delivery and the other is for gas and pressure monitoring. Even with neuromuscular relaxants provide optimum anesthetic conditions. Next is supraglottic ventilation. This uses short, narrow bore catheters attached to the suspension laryngoscope. However, disadvantage is that upon jetting, this may produce movements or vibrations of the cord. This may produce gastric distension, and fragments of tumor, blood, and debris may be blown into the distal airways. Barotrauma is also a significant complication. Another method is subglottic jet ventilation, where specially designed small catheters or tubes are inserted through the laryngoscope and pass through the glottis. Advantages include better minute ventilation, no movement of the cords during jet ventilation, and when using high-frequency ventilators, there's a lower risk of barotrauma. For transtracheal jet ventilation, a kink-resistant catheter or cannula is placed through the cricothyroid membrane. This is done under local anesthesia in those patients with significant airway obstruction. Among the three techniques mentioned, this has the greatest risk for barotrauma. Among the different complications associated with jet ventilation, barotrauma, as I said, is the most significant. And to avoid this, we need to maintain an unobstructed upper airway to allow for passive exhalation. So one of the things you have to watch out for is the movement of the chest, and we have to make sure that we have an airway in place so that this allows passive exhalation during these procedures. Next, you have high flow nasal oxygenation or transnasal humidified rapid insufflation ventilatory exchange, or THRIVE. This is a promising new technique for anesthesiologists because aside from prolonging safe apnea time to as much as 25 minutes, it also reduces the rate of carbon dioxide rise during apnea. This is achieved by a combination of cardiac oscillations and turbulence from the high flow nasal oxygenation. So it's been used in shared airways and microlaryngeal surgery, also in difficult airways, and it aids in awake intubation. Application of suspension laryngoscope causes intense surgical stimulation from the pressure on the base of the tongue, hypopharynx, and larynx, producing significant cardiovascular and respiratory effects. So techniques to minimize these cardiovascular responses include increasing anesthetic depth, giving additional narcotics. Presidex has worked, calcium channel blockers and beta blockers have worked, and of course topical anesthetic spray. In rare cases, severe bradycardia or sinus pause have been observed, and these have been reversed by the release of retractors and by giving of ephedrine. Lasers are one of the specialized equipments used in microlaryngeal surgery. They allow precise targeting of lesions with minimal edema and bleeding. Airway fire is the most significant hazard because all three elements of the fire triad are present. So question, how much oxygen to give during these procedures? The recommendation is to use the lowest FiO2, which provides adequate oxygenation. FiO2 of 44 has been reported to create ignition and sustain a flame. So it's been recommended that FiO2s less than 30 should be used as long as it's tolerated by the patient. To reduce the risk of fire, laser-resistant tubes have been used. There are different types of tubes, each one with its own advantage and disadvantages. The one we use is the Laser Flex tube by Mallinckrodt. It has two cuffs, and the second cuff provides a backup in case the proximal cuff is damaged. There are no depth markings, however, so it's difficult to assess the depth. So what we usually do is just mark the 20 cm level with tape and gauge the depth of insertion from there. The cuff is usually inflated by saline plus methylene blue to alert us of cuff rupture. This advantage usually, because they have a larger external diameter, this may interfere with the surgical view in some cases. Lasers may also pose additional risk for the OR staff, thus they have to wear appropriate masks. Drapes need to be soaked in water because of misdirected laser beams can cause fires. And also appropriate eye protection need to be worn by the patient and the OR staff to protect eyes from, again, misdirected laser beams. So what do we do when there is an airway fire? First, you have to stop the procedure, turn off the oxygen, disconnect the circuit, and remove the object on fire, which is usually the endotracheal tube in airway cases. The surgical field needs to be flooded with saline, and the patients need to be ventilated by 100% O2 by mask. In most cases, you have to reintubate so that we can do flexible bronchoscopic examination to assess airway damage. Now, ENT surgeries are associated with higher rates of complications after emergence and extubation, and these include laryngospasm, airway edema, post-operative airway obstruction, the need for reintubation, or gastric aspiration from functional changes in the airway. So smooth emergence and extubation, rapid awakening, which is devoid of coughing, bucking, or straining, are the goals of emergence. We need to allow recovery spontaneous ventilation prior to starting emergence and extubate when patients are awake and follows commands. Of course, during this time, blood pressure should also be controlled. We've discussed the important preoperative considerations and airway management strategies. Next, we will talk about the key anesthetic issues for some of the more common surgical procedures these patients may undergo. First is endoscopic transoral laser microsurgery. This is a minimally invasive technique that uses special equipments like endoscopes, operating microscopes, and lasers for treatment of laryngeal cancer. This is usually done under general anesthesia with open or closed techniques. Now, early laryngeal tumors, as I've said, usually do not produce any significant area obstructions. These patients usually undergo biopsy or transoral laser resection, and most can be managed by IV induction of general anesthesia and the use of cuff tubes. Supraglottic and subglottic ventilation can also be used. This requires intense paralysis to maintain a motionless surgical field. And among the most common complications is post-op bleeding, which occurs in 5 to 8% of cases and is associated with coughing or straining after extubation. Post-op stridor has also been observed in patients who are deeply sedated after extubation. This is less common when patients are extubated awake, and these can usually be managed by applying positive pressure, continuous positive airway pressure. Post-operative pain is usually mild. It's treated with paracetamol, opioids, and non-steroidal anti-inflammatories, and we usually give steroids post-operatively to reduce post-operative edema. For advanced tumors with airway obstruction and stridor at rest, the options are a bit limited. IV induction may lead to total airway occlusion. Awake fiber optic intubation may not be suitable because the scope needs to pass through the tumor and may lead to critical airway obstruction. So options that are left are tracheostomy under local anesthesia or even a transtracheal catheter placement done under local anesthesia. Next, you have transoral robotic surgery. These are done for malignant lesions that are too large or too complex for standard microsurgery. Some logistical issues with this: we need to use extra long anesthetic breathing circuits and IV lines because the anesthesia machine is located at the foot of the bed. Pressure points need to be checked and padded, and these patients' eyes and face need to be protected with appropriate paddings and goggles and appropriate other foam paddings for the face. Dental guards are also used to protect the teeth from trocars and retractors. In these cases, patients are intubated via nasal route using a reinforced armored endotracheal tube. Neuromuscular blockers are given to avoid movement of the oropharynx and the larynx. And the anesthetics used could be inhalation of opioids, Tiva with propofol and remifentanil, and usually neuromuscular blockers are given throughout the surgery. Because of sustained gag application, this may lead to intraoperative sympathetic stimulation. Pain management is usually through NSAIDs, paracetamol, and opioids. And during the surgery, we follow a conservative fluid therapy or restrictive fluids to minimize post-operative edema. Post-op, you just have to watch out for airway edema, bleeding, aspiration, and airway obstruction. And in some patients, depending on the extent of surgery and its length, some may need to be extubated, either in delayed extubation or in some even a tracheostomy may be needed. Most patients, we recover them with the head elevated to somehow aid in drainage of edema fluid. Total laryngectomy is still one of the options as first-line therapy for those with advanced cancers or those with cancer recurrence. These patients may be elderly, hypovolemic, or malnourished from prior treatments. Surgery involves the end block removal of the larynx together with the hyoid bone, the thyroid, and the cricoid cartilage. The usual concerns, planning for difficult airway. Patients are usually old, hypovolemic, and malnourished. Some may have been treated with radiation treatment and are at risk for baroreflex dysfunction. The length of surgery and blood loss depends on surgical expertise. So some intraoperative goals, we need to optimize perfusion. We have to avoid fluid overload and tissue edema. We need to maintain normal temperature. And in most cases, we may have to use vasoactive agents judiciously. At the end of surgery, a laryngeal stoma is formed. Next, you have laryngeal conservation procedures. These are done to preserve laryngeal function like speech and swallowing and to avoid a permanent tracheostomy. Procedures involved include hemilaryngectomy, supracricoid partial laryngectomy. These are usually done under general anesthesia. Patients are extubated after. In some patients, a temporary tracheostomy may be needed but are usually decannulated after several days to within a month after surgery. Pain management is similar to open neck procedures. Now, some of these patients may need a tracheostomy or end up with a laryngectomy stoma. These may present significant implications for perioperative airway management, and knowing the difference between the two is important. With the tracheostomy, the larynx is intact and is still connected to the oropharynx. In cases of loss of airway, patients with a trach may be oxygenated and ventilated from either the tracheal stoma or from above through the nose and mouth. The tract between the skin and the trachea takes 7 days to mature, so blind replacement of a trach before the stoma is established is highly discouraged because of possibility of false passage. Now, the National Tracheostomy Safety Project in the UK have developed head-of-bed signs. These are easily visible to those responding during emergencies, and it contains data on what techniques was used and other significant information for airway management. For total laryngectomy patients, there is no communication between the upper airway and the trachea. These patients need to be identified as they are neck-only breathers. Oxygen can be delivered only through the laryngectomy stoma. It is impossible to oxygenate with nasal cannula or bag mask ventilate or intubate from above. Now, in case the laryngectomy tube is dislodged, the stoma can be oxygenated using a PEDS anesthesia mask or an inflated laryngeal mask until a more definitive airway is placed. Aside from the head of bed signs, there are algorithms to aid in management of these emergencies. Time constraints do not permit a detailed step-by-step discussion of the algorithm in this talk, but you can go and visit this website. Key points to remember during these emergencies are 1. Don't panic, and 2. Remember to oxygenate the face and the neck for patients with a tracheostomy and the neck for laryngectomy patients. If you're not sure whether the patient has had the laryngectomy or tracheostomy, the default action would be to oxygenate both with high flow oxygen. Expert opinion on the management of difficult airway cases may differ, and the level of evidence favoring one technique over another may be low. So determining the best anesthetic management should be based not only on existing principles and guidelines, but also upon consideration of the nature of the lesion, the severity of obstruction, the condition of the patient, the surgical and anesthetic expertise, availability of equipment and resources, and the urgency of the procedure. This editorial states that airway management is context sensitive and that it is dependent on the clinical situation at that particular instance. Key points, we need to plan strategy according to the context that appears before us, and this may have to be changed depending on the factors mentioned. Focus should be less on specific devices or techniques, but more on principles of gas exchange like oxygenation and ventilation. In summary, Patients with laryngeal cancer may pose some challenges for us because of a difficult and shared airway. We need to perform a thorough preoperative evaluation with meticulous airway assessment. In planning for the anesthetic management, we should take into context the nature of the lesion, the expertise of those involved in patient care, the availability of resources, and the urgency of procedure. Careful planning and communication is essential. Primary and backup plans need to be discussed between anesthesiologists, surgeons, and nurses, and it is important to immediately recognize that our primary plan may not be working and to quickly shift to an alternative technique. Anesthesia has often been compared to aviation. We've adopted aviation concepts like risk assessment, critical decision making, and resource management. And just like flying a plane, we want the whole perioperative period to be smooth and uneventful by using our skills and judgment to avoid these highly stressful situations so we can safely bring back our patients from their surgical journey. With that, I'd like to thank you all and I hope you have a good afternoon.
Thank you, Dr. Policarpio. Again, if you have any questions, you may type it in the Q&A box for the open forum after this series. So common and unique among the non-operating room anesthesia services is brachytherapy. And we have two speakers to share their expertise today. Our first speaker is a radiation oncologist who graduated from UERMMC and had his residency training at the Jose R. Reyes Memorial Medical Center. He subspecializes in intraoperative radiation therapy, image-guided radiation therapy, and brachytherapy. He was a past chairman of the board of the Philippine Board of Radiation Oncology and is currently a member of the Executive Council of the Philippine Society of Oncologists. He is a consultant at the UST Hospital, Chinese General Hospital, and the Medical City, and currently the chairman of the Lipa Medics Cancer Center in Batangas. Our first speaker is Dr. Gonzalo Banuelos Jr. Following Dr. Banuelos, our next speaker is a colleague in anesthesia, a graduate of the UST Faculty of Medicine and Surgery, and had her residency training at the UST Hospital. She had her fellowship training in critical care at the National University Hospital, Singapore. She has also imparted her expertise in our past national conventions. She was an assistant professor in physiology at the CGH College of Medicine, and currently she is the resident training officer at the Department of Anesthesiology of Chinese General Hospital and Medical Center. She is a person who exemplifies the meaning of silent water runs deep. Friends, Dr. Christine May Lutian. Ladies and gentlemen, our two speakers, Dr. Gonzalo Banuelos Jr. and Dr. Christine May Pan Lutian.
Good afternoon. It is my privilege to be a part of the 13th biennial postgraduate course of the Department of Anesthesia and Perioperative Medicine of the UST Faculty of Medicine and Surgery. Today, I will be talking about perioperative management of patients for brachytherapy, an overview. I have no disclosures. The outline of my topic would be what is radiation therapy. I will be defining what is brachytherapy and the brief history of brachytherapy. The fourth part would be what are the most common radionuclides used for brachytherapy. The fifth would be the components of brachytherapy and what are the classifications of these brachytherapy. Then we will be focusing on the high dose rate brachytherapy, which is what is most commonly used today, and the different clinical applications of the high dose rate brachytherapy. So what is radiation therapy? It is a form of treatment wherein we deliver a precisely measured and highly ionizing dose of radiation to the tumor that will kill these cancer cells. We aim to deliver this radiation dose accurately and precisely on a regular basis. At the same time, we want to minimize the radiation dose to the normal critical structures because, as we all know, every tumor has a surrounding normal organ, or what we call the organs at risk. So we want to minimize the radiation doses to these organs at risk so that there will be minimal morbidity. Our aim is to improve the patient's quality of life and extend the life expectancy. Radiation therapy would be given in 50 to 60% of all cancer patients as part of their treatment. So, what is the target of radiation therapy? The target of radiation therapy is the tumor DNA, be it external radiation or internal radiation. The aim is to hit that DNA and then make that DNA unable to replicate, thereby killing the tumor cell. So we have two kinds of radiation, mainly external beam radiation, or what we all know as a cobalt machine or a linear accelerator, and an internal radiation, which is what is known as brachytherapy. So for this topic, for today, we will be dealing mainly with internal radiation or brachytherapy. So what is brachytherapy? Brachytherapy is internal radiation therapy. It is a form of radiation therapy with technique which is performed by placing a sealed radioactive source close to or in contact with the target tissue, as opposed to external beam radiation, wherein the radiation would be coming from the outside. So in brachytherapy, the radiation is placed inside the target. The objective is to deliver the highest possible dose of radiation to a limited volume of tumor and spare the normal surrounding tissues. Brachytherapy could be used in combination with external beam radiation, as in the case for cervical cancer, or as a sole treatment for prostate cancer, for example, or for early stage endometrial cancer. So brachytherapy is a precise answer for tackling cancer. It derives from the Greek word brachus, which means short distance. Brachytherapy involves placing a radioactive source internally, either into or immediately next to the tumor, allowing precise radiation dose delivery. So brachytherapy is treating the cancer from the inside out, as opposed to external beam radiation, which works from the outside in. So, when did brachytherapy start? Actually, in 1895, Wilhelm Conrad Röntgen discovered the X-rays, and at the same year, Henry Becquerel discovered radioactivity. Shortly thereafter, Marie Curie and Pierre Curie discovered radium, which is a radioactive source, and used that to treat basal cell epithelioma of the arm by placing the radium seed directly into the tumor, thereby curing it. So brachytherapy has a substantial heritage. In 1901, it was first used to treat lupus erythematosus and then malignant tumors. In 1903, the use of brachytherapy to treat a gynecologic malignancy was first reported. In 1917, the techniques developed were the techniques to treat prostate cancer were already developed. And in the 1950s and 1960s, as new radioactive sources were discovered, new techniques and equipment were also done, which prevented unnecessary radiation exposure to the patients as well as to the clinicians, and this led to a renaissance of brachytherapy. In the 1970s, it was established as a safe and effective standard of care for many gynecological cancers, and today it is a valued treatment option for many types of cancer with a wealth of supporting evidence. So, what are the most commonly used radionuclides? Before, the first radionuclide that was used for brachytherapy for cervical and endometrial cancer was the radium-226 at the bottom of the screen. And this emits alpha particles, but the problem with that is it has a half-life of around 1,599 years, meaning that we are all dead, but still the radium-226 seed is still in activity. So this was slowly replaced first by cesium-137. Cesium-137, we usually use this for low-dose brachytherapy of the cervix. And then the iridium-192, which is the more commonly used radioisotope now for high-dose rate brachytherapy, as well as the cobalt-60 source, which is recently developed for use for high-dose rate brachytherapy. For low-dose rate brachytherapy, such as seed implants, they usually use iodine-125 and also gold. So these are the most common radioactive sources that we use for brachytherapy, be it low-dose rate or high-dose rate brachytherapy. So what are the components of brachytherapy? Remember that the plan is to deliver a precise treatment. So brachytherapy is able to deliver these precise treatment through a combination of imaging or computer-based planning, treatment delivery techniques, and specialized applicators. So you have imaging wherein you see where the tumor is by using clinical examination and tumor imaging, such as using X-rays or using the ultrasound as well as CT scan. Then apply the source, the applicators inside the body for accurate positioning, optimizing treatment plan, and then the delivery of the radiation. So the brachytherapy is actually a multidisciplinary approach. So we have these team that would treat the patient. So you have clinician, the referring patient, the referring doctor, the medical oncologist or the gyne oncologist or the urologist, and then together with the radiation oncologist would be placing the sources or the applicators inside the patient. Of course, we need the anesthesiologist so that the patient would not be moving. And then after placing these sources, we have the nurse, okay, which helps us during the procedure. And then for the treatment, we have the medical physicist and the radiation therapist. So this is a truly multidisciplinary approach to cancer care. So what are the different classifications of brachytherapy? We can divide it into three. We have one, the source placement, two, the duration, and three, the dose rate. First, we go to the duration. It could either be a permanent brachytherapy where the source is implanted permanently, such as in prostate seed implants, as well as in tongue implants. So you have here radioactive seeds that are placed there permanently. And we have a temporary, which is a source implanted for specific treatment duration. Now, most brachy treatments are temporary for a wide variety of cancers, such as cervical cancer. The other classification is the dose rate. You have a high dose rate, meaning you give 12 grays per hour, and this could be done for patients with breast and cervix cancer, as well as for prostate interstitial implants. So this is usually temporary, and the patient is usually treated in a span of about a few minutes to an hour. And a low dose rate brachytherapy, which gives 0.4 to 2 grays per hour, and this is usually given for prostate cancer and oral cancer, which is delivered using the seeds, and this is usually permanent procedure. So we now focus on high dose rate brachytherapy. The high dose rate brachytherapy uses applicators to put the radioactive source close to the tumor. And we have these four different kinds of high dose rate brachytherapy. First, you have the superficial, wherein you just place the radioactive source on top of the tumor, such as in the skin or in the lymph nodes of the neck. You have intracavitary, wherein you use an applicator inside the cavity, such as in nasopharyngeal cancer and in cervical as well as endometrial cancer. We have intraluminal, which is wherein you use the lumen, such as in bronchial cancers and esophageal cancers. And interstitial, wherein we use interstitial needles to go and penetrate inside the patient's body. So these are the key components of brachytherapy. You should have an afterloader, the device wherein the radioactive source is housed and which delivers the radiation. You should have a treatment planning software, which optimizes the radiation dosage to the target, and an applicator to deliver this radiation. So this is how an HDR brachytherapy actually looks like. So this is an HDR brachytherapy machine. You have different channels, those circles there, where a catheter is inserted, and at the end of this catheter is the applicator. So we now go to the clinical applications of brachytherapy. These are the areas of the body where brachytherapy can actually be used. The brain, the eyes, the lips, the mouth, tongue, nasopharynx, and oropharynx, as well as the trachea, the bronchis, and the lungs, and the esophagus, the gallbladder, the bile ducts, the rectum, and the anus, the bladder and the urethra and the skin, and soft tissues. For females, breast can also be used. We can also use brachytherapy for breast cancer as well as for uterine, cervical, vaginal and vulvar, and for the males, prostate and the penis. But with the advent of the stereotactic radiosurgery and stereotactic radiotherapy, some of these sites, such as in the brain, brachytherapy is not normally used nowadays, but it is still a mainstay of treatment for prostate, especially, and for uterus and cervical cancer. And these are the major applications. But sometimes we also use brachytherapy for head and neck cancers as well as for soft tissue sarcomas. So, first application is for gynecologic tumors. For gynecologic cancer, it is mostly used for cervical and endometrial cancer, either as a sole treatment or in combination with external beam radiation therapy. Now, most of the cases we see in the brachytherapy center is gynecologic, around 80 to 90% of the cases in a particular center. And we either use intracavitary and interstitial radiation. Now, for an intracavitary, for example, cervical cancer, it is an outpatient treatment, and it's usually a 2-hour procedure. Anesthesia given can either be propofol, Severin, or spinal anesthesia. And if it is an interstitial radiation, interstitial technique, then this is as an inpatient, wherein the patient would be treated for the following 3 to 5 days, and the usual anesthesia given is epidural. So what is the procedure for doing brachytherapy of the cervix? Also, this can be used for endometrial. So first, the patient undergoes anesthesia, either spinal or general anesthesia, and then sterilization of the perineal field. We then insert an indwelling catheter and a rectal marker. Then we do hysterometry to measure the length of the uterine canal. We insert the intracavitary applicators. One applicator is placed inside the uterus, and then the other two is in the vaginal canal. Then after placing these applicators, the patient undergoes either a C-arm, or if it is an image-guided brachytherapy, a CT scan. Then we do treatment planning. After treatment planning, we approve the plan, then we deliver the radiation. After delivering the radiation, the applicators are removed, the indwelling catheters and the rectal markers are removed, and then the patient is placed on the recovery room and is sent home after around 30 minutes. So the whole procedure is around 2 hours to 2 hours and 30 minutes. So these are the applicators for cervical cancer. We have the Henschke applicator. One of these are inserted, one of the, what we call the tandem, is inserted inside the uterus, and then the other two are placed in the vaginal canal. This is the HDR applicator for an intact uterus, intact endometrial cancer. So we have an intrauterine vaginal cylinder. And these are vaginal applicators for post-operative or post-Tabiso endometrial cancer. So the cervical cancer, this is what would look like, what it would look like after inserting the applicators. One is inside the uterus, and then the other two, which is what we call the tandem, and then it is placed into the vaginal canal. Now this is a Venetia hybrid applicator, which combines intracavitary and interstitial techniques. So you have needles that are inserted inside the perineum of the patient, and usually when we use this is for big cervical cancers that cannot be treated with the Henschke or the Fletcher suit applicators alone. So this one is applied for about 3 to 5 days, and then it would be removed. So it is not on a weekly basis. Now, what are the acute side effects of brachytherapy? For the gastrointestinal tract, there are none. But for the genitourinary tract, there could be dysuria. There could be some form of bleeding coming from the tumor or from the uterus, and there could be vaginal discharges. For the skin, there is no side effect for the skin of a patient undergoing brachytherapy of the cervix. And the late effects of brachytherapy, but this would be in combination with external beam radiation. For the GIT, could have the patient could suffer from proctitis, colitis, rectal bleeding or fistula. For the genitourinary tract, patient could have cystitis as well as a fistula. And for the skin, there could be some ulceration. Now, this could occur in around 4 to 8% of patients. So another clinical application is for prostate cancer. For prostate cancer, there are two choices. You have a low dose rate brachytherapy, wherein you use permanent seed implants, or a high dose rate brachytherapy, where you use interstitial needles. For low dose rate seed implant, the patient is admitted. On day zero is the admission date, and the pre-operative procedures are done. On day one, the patient undergoes anesthesia, either spinal or epidural, and insertion of these permanent seeds. And this is ultrasound guided and can be done for about 2 to 4 hours. And then after that, the patient undergoes observation. The following day, the patient is discharged. So this is how the LDR seed implant is done. You have a specialized ultrasound probe that is inserted into the rectum, and then the specialized needle that carries the radioactive seeds is inserted transperineally. And a skillful urologist and radiation oncologist can do this procedure for around 2 hours. And then all of these would be removed and the patient can be sent home the following day. So LDR brachytherapy for both low risk and selected intermediate risk cancers achieves exceptional cure rates. And this is how the radioactive seeds would look after the procedure. So this is left there. It would decay in time, and sometimes the seed are just left inside the prostate. Sometimes it can go out and migrate and travel outside. The patient could see it in his defecation afterwards, but this would be for after a few months. So what about high dose rate interstitial implant? So day zero, admission and preoperative. Day one, again, the patient would undergo anesthesia, which is epidural, insertion of the interstitial needles, and then imaging and verification. After that, we do planning and delivery of the first fraction. Okay. Then after that, on day two, another imaging would be done, and then the delivery of the second fraction of radiation. After 6 hours, delivery of a third fraction of radiation. Then patient goes back to the room. On day three, another imaging is done, and then if the plan is to deliver 4 fractions, and the patient undergoes the fourth fraction of radiation of brachytherapy, and then the needles are removed, and the removal of the epidural catheter, and then observation. On day four, the patient is discharged. The number of fractions actually may vary, but usually you give 2 fractions per day, 6 hours apart. And the number of sessions could either be for 3 days or up to 5 days. So this is how high dose rate brachytherapy is done. Again, you have an ultrasound probe inserted into the rectum, which would serve as a guide, and then transperineally insert the interstitial needles and leave it there at the prostate. And then this would be fixed, and then patient would be treated on a daily basis for about 3 to 5 days, and then permanently it would be removed. So another clinical application is for head and neck cancer. You have tongue, floor of the mouth, buccal mucosa, and nasopharyngeal cancer. The technique can either be for the tongue is permanent seed implants or interstitial needles. Floor of the mouth and buccal mucosa, you can use interstitial needles. And nasopharyngeal cancer carcinoma is intracavitary. So this is an example of a Rotterdam applicator for nasopharyngeal cancer brachytherapy. So you insert it through the nose and then radiate that part of the nasopharynx. So this could be done under sedation. For tongue cancer, so the interstitial needles are inserted into the mouth here, and then go through the tongue. And this stainless steel needles would then be replaced by plastic catheters. Leave it there for about 3 to 5 days, and then treat the patient on a daily basis. And another application is for soft tissue sarcomas, wherein during the operation, when the soft tissue sarcoma is removed, then we place these interstitial needles, these catheters, and then close the patient up. After a few days, the patient would undergo brachytherapy by inserting the catheters into the treatment area. So that would be my last slide. Thank you very much.
Hello, good afternoon. Let us now discuss the anesthesia considerations for brachytherapy. My objectives for this lecture are as follows. To identify challenges, enumerate goals, and to present different anesthesia techniques for providing anesthesia for brachytherapy, weighing benefit versus risk. The unique challenges faced by anesthesiologists for brachytherapy can be grouped into two factors: one, ambulatory procedure, and two, remote location. The more common HDR intracavitary type is less painful, typically lasts 80 minutes, and can be done as an outpatient procedure. Brachytherapy is performed mainly in the cancer center, where there is a designated radiation treatment room. But part of the treatment process may require patient transfer to various locations in the hospital, for example, CT scan or MRI for imaging. Having said that, let us review the guiding principles of ambulatory anesthesia. So number one, careful patient selection and preparation. Patient suitability should be assessed on the basis of overall health. Chronic conditions must be relatively stable and optimally treated. Remember, obese patients benefit from early mobilization, use of short-acting drugs, and avoidance of opioids. 2. There is no best anesthesia technique. Anesthesia must be tailored to each patient, weighing pros and cons. 3. Enhance recovery with minimal adverse events. For example, PONV can be reduced by giving acetaminophen or NSAIDs to reduce need for opioids. Provision of effective post-operative analgesia, appropriate information, and post-operative support. The anesthesiologist should be knowledgeable about the patient, the procedure, and the environment. At the brachytherapy suites, check for provision of anesthesia equipment, anesthesia machine, monitors, oxygen source, suction, anesthetic and emergency drugs, e-cart, and defibrillator. Other concerns include 1. Radiation exposure. Treatment room is actually shielded. The radioactive isotope has a shield casing, which is called the afterloader, that is remotely activated. Number 2, restricted access. The patient is left alone in the room during treatment, and in case of emergencies, treatment can be interrupted, but it takes time for radiation to decrease to minute levels so that it is safe for personnel to go in. Number 3, CCTV and intercom allow monitoring and communication with the patient from a distance. Number 4, there may be limited space to move as a lot of equipment like anesthesia machine, oxygen tank, C-arm, etc., and personnel are in the room at the same time. Identify a strategic position where easy access to the patient can be gained. 5. Treatment duration is variable. Ensure patient is safe with good pain control and immobile during radiation treatment. So, what are the challenges unique to brachytherapy? Most patients are elderly with concurrent comorbidities, which put them at risk for perioperative complications. Studies report that more than one-third were high-risk ASA3 or 4, and 40% were 60 years old and above. Adequate analgesia to maintain immobility during applicator placement up to its removal should be provided. Duration of brachytherapy is highly variable. For intracavitary, it may take a few hours. For interstitial, a few days. It may require transfer of patients to various locations in the hospital. For example, after applicator insertion, the patient might be brought to CT scan or MRI for imaging, and then back to the isolated radiation room for treatment.
Any movement can increase stimulus and worsen the pain. Thus, provision of analgesia that is safe and effective during patient transport is important. Monitoring the patient and maintenance of anesthesia at the different locations, such as in MRI, which requires MRI compatible equipment, pose an additional concern. Lastly, quick emergence is required because most brachytherapy units lack a dedicated practice. The goals of anesthesia are as follows: ensure patient safety, provide adequate analgesia, maintain immobility to ensure proper placement of applicator and adequacy of treatment, promote rapid recovery with minimal side effects. Choosing the appropriate anesthetic technique considers the following factors together: patient factors such as obesity, difficult airway, comorbidities, contraindications to regional anesthesia such as use of anticoagulants, previous spine surgery, and etc., and of course, patient preference. 2. Body region of brachytherapy. Brachytherapy may be needed for endobronchial tumors, head and neck tumors, urologic, and gynecologic cancers, to name a few. Knowledge of the procedural site, its innervation, and neurological distribution is important in formulating an anesthetic technique that ensures adequate anesthesia and analgesia. For example, insertion of a tandem applicator into the body of the uterus involves T10 to L1 sympathetic afferent. Cervix and upper vaginal distension from ovoid ring applicator placement relates stimuli to S2 to S4 pelvic splanchnic parasympathetic nerves. Vaginal packing and labial sutures produce somatic stimulation from the pudendal nerve, S2 to S4. Inadequate analgesia may present as cramping, lower abdominal pain, or lower back pain. Patient movement exacerbates stimuli and magnifies pain. Duration of treatment: short duration, 2-hour procedure like intracavitary HDR brachytherapy, benefits from a technique that provides rapid recovery with minimal side effects. In contrast to long-duration treatment with multiple fractions like interstitial brachytherapy, which takes 3 to 5 days to complete, analgesia has to maintain throughout since the applicator is maintained in place for the duration of treatment. Interstitial brachytherapy and hybrid or a combination of intracavitary and interstitial brachytherapy need stronger pain control and have different requirements. With intracavitary brachytherapy, the radiating sources are placed within body cavities, whereas interstitial brachytherapy, it is within the tumor. Intracavitary is less invasive compared to interstitial. Commonly, analgesic requirements are limited to the most painful parts of the procedure, insertion and removal of applicators. It is of short duration, 2 to 3 hours, and can usually be done as an outpatient procedure. Interstitial brachytherapy has worse pain scores due to the more invasive nature of the applicator or needle placement. For example, for cervical CA, it requires more vaginal packing, vaginal sutures, and hardware retained in the patient at least overnight for a series of radiation treatment, thus necessitating hospital admission. Other considerations for choice of anesthesia include the availability of anesthesiologists. 2. Logistics and configuration of treatment centers should address practical workflow concerns such as locations involved, coordination with CT scan or MRI, equipment, monitoring, and manpower available. Is there a designated factor? Personal preference of providers. Consider what is safe. Can the patient be left alone and be safe during radiation treatment for a variable period? It may take as long as 45 minutes. Can he be safely transported to the required locations in the hospital? Can anesthesia be easily continued in these locations? What are the facilities? What are the monitoring equipment? Consider what produces effective analgesia to maintain immobility. Consider what is feasible, what is the setup, the facilities available in your institution. Consider what is easily reproducible, as patients may have 3 to 4 times repeat treatments. We have actually made an acronym of what we should consider as we formulate our anesthesia plan. First and foremost, to keep the patient safe. At present, there is no ideal anesthetic technique of choice for brachytherapy. This table summarizes the advantages and disadvantages of the different types of anesthesia. Local anesthesia and sedation, usually performed by non-anesthesiologists, may produce inadequate analgesia. Occurrence of pain during brachytherapy results in inferior conditions. Insufficient analgesia relates to a high degree of discomfort for the patients. Low level of patient satisfaction may pose a risk to successful brachytherapy as patients are unable to stay still. Patients may even refuse further brachytherapy treatment. Banabay et al. Stated that conscious sedation with midazolam and opioid combination for intracavitary brachytherapy achieved adequate pain control with minimal side effects. For most patients, maximal level of pain was 5 out of 10. 2 periods of intense, painful stimuli were identified: insertion and removal of applicator. Giving patients opioid boluses prior to insertion and removal of applicator improved pain scores. Fentanyl, with its fast onset and rapid clearance, is the analgesic of choice. In the study, a patient who was virginal with an intact hymen required general anesthesia. Watanabe, Nemoto et al. Showed that sedation with a combination of propofol and ketamine was safe and effective for HDR intracavitary brachytherapy. Propofol was administered via PCA with basal infusion and demand bolus, and ketamine was titrated during applicator insertion. Similar to Banabay et al., VAS pain scores of nulliparous, virginal, or women who had vaginal tightening surgery was higher than parous women. Alternative anesthetic technique with better analgesia should be provided to this special subset of patients. General anesthesia, whether inhalational or IV, ensures analgesia and immobility, but requires full anesthetic equipment and ventilator, which may not be available in other areas, such as the MRI. Benrath et al. Presented a 5.5-year experience of anesthesia for brachytherapy, comparing GA versus RA. For GA, majority of complications are cardiovascular incidents. There was a higher incidence of PONV and increased need for post-operative analgesics. Unique problems associated with regional anesthesia include post-dural puncture headache, technical problems such as multiple attempts, and accidental removal of catheter occlusion, and insufficient analgesia as reasons for switch from RA to GA. Caudal epidural block for intracavitary brachytherapy for cervical CA with 10 ml of 1% mepivacaine was shown to have insufficient pain control with mean NRS of 5.17 because of the inability to achieve a T10 to L1 block to block pain from the presence of applicator rods to the body of the uterus. Schenk et al. Compared pudendal block versus CSE for HDR prostate brachytherapy Average duration of treatment was 80 minutes. Patients who received pudendal block were able to complete treatment successfully. Pudendal block was easier to perform, 10 minutes compared to 30 minutes for CSE, and had better postoperative mobility. Excellent analgesia, good sense of well-being, and no significant side effects were present in both groups. Pudendal block can be performed using the ischial spine as a landmark, and the block can be facilitated with the use of an ultrasound. It is a desirable option for patients with previous spine surgery and advantageous with regards to patient positioning as no change is necessary. Regional anesthesia is advantageous for brachytherapy of the lower body. It provides sufficient analgesia and immobilization, result in high degree of patient satisfaction, and it's safer to transfer patients between different locations compared to general anesthesia. Options include spinal, lumbar epidural, combined spinal epidural. Spinal anesthesia produces rapid onset of analgesia but may not be enough for lengthy procedures. Catheter technique gives more flexibility, being able to give top-up doses, and can provide analgesia in between treatment sessions for interstitial brachytherapy with continuous local anesthetic opioid infusion, and enables giving a bolus dose of local anesthetic just before removal of the applicator. Combination of spinal and epidural get the best from both techniques. A retrospective study by Kumar et al. Of 10 patients who had 16 brachytherapy sessions for prostate CA showed that CSE is an effective technique achieving post-op NRS VASP 2 to 4 in all patients for 24 hours. Good patient satisfaction score with minimal side effect. Petty et al. Performed a meta-analysis comparing RA versus GA in women who underwent HDR or intracavitary brachytherapy. Neuraxial anesthesia group had improved pain control, decreased frequency in rescue analgesic administration, and similar rate of anesthesia-related complications. Thus, RA is more favorable for pelvic brachytherapy. Nielsen et al. Compared epidural versus CSE versus MAC with paracervical block. Sedation was concomitantly used with a variety of agents. This is the protocol for CSE and epidural technique. For sedation, midazolam and fentanyl combination were most commonly used. In 1/4 of cases, propofol was used. Presidex, ketamine, or remifentanil are less commonly used. For the period in between treatment sessions wherein the hardware remains in place, 90% had continuous epidural infusion. Most common IV post-op analgesic is hydromorphone. Most commonly administered antiemetic was IV ondansetron. The CSE group had the lowest post-operative pain scores and lowest rescue IV hydromorphone dose. Most common complication is PONV, especially if hydromorphone dose exceeded 5 milligrams in 24 hours. 71% of whom received a basal rate on their PCA hydromorphone. The association of delirium with basal PCA use was statistically significant. To optimize patient management, they developed this perioperative pathway, minimize NPO to decrease PONV and improve a sense of well-being, anxiolytics on an as-needed basis only to avoid delirium and oversedation, minimize overall narcotic administration with IV paracetamol, avoid ibuprofen and ketorolac as they have the potential to worsen vaginal bleeding, and based on high rates of PONV, ondansetron is first line for prophylaxis. Maintain good hydration status to prevent PONV. Humphrey et al. Performed a systematic review of women's experiences of brachytherapy for cervical CA so that considerations could be given to patients' needs. To improve patient experience, the following must be achieved: better pain management, adequate patient information, development of non-pharmacological intervention, develop clinical support guidelines, audit the quality of services, and develop effective interventions to improve patient experience of brachytherapy. Brachytherapy causes anxiety and distress for most women. Most reports of anxiety were either underreported or underreported by the patients themselves or underestimated by healthcare workers. Anxiety levels take a long time to reduce, and these women have shown to fail to adapt. Anxiety is significantly lower for married or widowed and those with 2 or more children. The incidence and severity of anxiety and distress are variable. Brachytherapy was said to be more stressful than EBRT or chemotherapy. Patients had varying degrees of pain, as much as 10% 10% with severe pain. Significant recall of pain from previous brachytherapy was reported in around 30 to 60% of patients. Distress decreased with each procedure, and discomfort was experienced as a totality and not limited to pain alone, such as feeling of humiliation, being exposed, cold environments. Pain was most frequently reported as the most stressful experience with brachytherapy. Non-pharmacological options can supplement pharmacologic approach. It is simple, effective, non-invasive, and inexpensive. Provide women with some control of their well-being during brachytherapy. Minimize observers and staff changes. Provide individualized patient information, such as fasting, maintenance medications, the treatment itself, the side effects. Information should be delivered verbally and written in the patient's own language. Patient reassurance after their treatment is important. Indeed, anesthesiologists are like rare gems in the field of medicine. We discover our value in our expanding role in our field. It is not about just giving good anesthesia, it is alleviating pain and suffering. It is making something unbearable bearable, something terrifying as nothing to fear. We find ourselves making an impact, one patient at a time. Thank you.
Thank you, doctors, for those lectures. We would like to open the floor for our open forum. May we invite Dr. Panuelos, Dr. Policarpio, and Dr. Alitian to join us for a few. Good evening, doctors.
Evening.
Thank you
Hello,
for being with
Roxanne.
us.
Hi.
Hello.
Evening.
Thank you, doctors. For our first question, I will address Dr. Policarpio. We have a question regarding airway. How can we perform a safe emergency intubation for a COVID patient with a recognized difficult airway? What is your stand on the use of muscle relaxants? Because we know that it is for COVID patients, we would like to have paralyzed patients, right?
Okay,
Yes, Dr. Policarpio.
for COVID patients with a recognized difficult airway, of course, you have to still follow the core principles of airway management. Again, management is context dependent. There are several factors, but of course, you have to follow the basic tenets of pre-oxygenation. And in fact, patients may have to be pre-oxygenated longer than the usual because we want to avoid as much as possible bag mask ventilation because it's been shown to be aerosol generating. And in cases we have to do these difficult airways for laryngeal surgeries, the recommendation is to use closed techniques, intubated techniques in securing the airway. So we do away with jet ventilation and awake techniques.
Okay, thank you, Dr. Policarpio. We would like to ask the next question for Dr. Banuelos. Uh, Doctor, how soon after, this is for the safety of the anesthesiologists that give the anesthesia for brachytherapy, how soon after interruption of treatment can the anesthesiologist enter the room?
Okay. So we're mainly using now a remote afterloader, meaning we are all outside the treatment area during the radiation treatment of the patient. So we're in the control room. So before we enter the room after the treatment has been completed, we have a monitor to measure the radiation dose, and if it's already nil, then we can enter. So that's usually around a few seconds only. Once we shut down the machine, we can already enter the room.
Okay. Thank you, Dr. Banuelos.
Okay.
And for Dr. Litian, what would your preferred what is your most preferred anesthetic practice for these patients for brachytherapy? You mentioned quite a few, and of course they have indications. But for you personally, what is your most preferred anesthetic practice for this?
Yeah, thank you, Roxanne, for that question. So, brachytherapy actually, initially you might think it's simple, but actually it's very complex and very challenging for the anesthesiologist, as you have to think of a lot of things, not just your anesthesia plan, but also the logistics of coordination with like various locations in the hospital. So for me, what I just want is to provide anesthesia that is safe for the patient, that will keep the patient comfortable, pain free, and also immobile, so he will be able to tolerate brachytherapy. So the challenge when radiation treatment is started is that the patient is left alone in the room. So for if you give regional anesthesia, then maintenance of anesthesia is actually not a problem anymore, since the patient is pain free. You don't need to sedate the patient, and you can just go safely outside of the treatment room and just monitor the patient from a distance. So the problem is if you're giving IV sedation, especially for, it's very hard to titrate the anesthetic remotely. Um, and then as you know, when you give conscious sedation, there's always the danger of having a deeper than intended level of sedation. So being away from the patient, it's important that you recognize this deeper than intended level of sedation, which can cause airway obstruction, hemodynamic instability, and apnea. So recognition is important, and also that time frame wherein you can rescue the patient. So as you mentioned earlier, it takes time. So we can interrupt the treatment, but there might be a few minutes, maybe 1 or 2 minutes delay before you can go inside the room and address the problem. So what is important is to keep the patient safe, comfortable, and immobile, so that we are ensured that treatment will be adequate.
Definitely, anesthesia for brachytherapy is no simple task. We have a question here for Dr. Banuelos. Can you give us a list of hospitals already performing brachytherapy here in the Philippines?
Okay. In Metro Manila, we have several. We have St. Luke's, we have, of course, UST, we have Medical City. In the provinces, also Makati Med, Inpatient Hospital also has, and Cardinal Santos also has. In the provinces, in Region 3, we have in Pampanga, we have it in Sacred Heart Medical Center. In Batangas, in Region 4, we have in St. Cabrini. And it's not as common as the linear accelerator. No? But in the recent times, we have been able to penetrate the other provinces. In Metro Manila, there's no problem, but in the provinces, really, there are only a few centers who has this.
Okay, thank you, Dr. Gonzalez. And for our last question, just for a quick for Dr. Rio Policarpio, if air is not available, is it possible to achieve FiO2 of 30%?
You need air.
Definitely need
So
air, yes.
especially as a resident before, we used to do tracheostomies under pure oxygen, and
Yes.
so looking back,
There's
it's
no.
really an unsafe procedure, and all the elements are there. So it's something that in case the OR doesn't provide that, you just have to insist on it.
Okay, thank you very much. Thank you very much, doctors, for answering our questions and for staying, for the very enlightening talks on this unique cancer surgery. Thank you very much, doctors. For this, we would like to award our certificates of appreciation to our dear speakers. We would like to give this to Dr. Ruben Policarpio, Dr. Christine May Lutian, and Dr. Gonzalo Banuelos Jr. Thank you very much, doctors, for joining us and for participating in our postgraduate course. Thank you.
Thank you.
For next, we have a sponsored lecture to be given by a graduate, also by in anesthesiology residency at the UST Hospital, and a speaker of Pfizer. Let us all welcome Dr. Noel Aipa.
Good evening. I'm Dr. Noel Aipa, anesthesiologist, and a graduate of the UST Anesthesiology Residency Training Program. I am a Tomasian by heart, and first of all, I would like to congratulate the UST Department of Anesthesia for its 13th postgraduate course. Today, I will talk to you about Perioperative, its role in acute post-operative pain management, and its possible cancer pain use. This is my disclaimer. And I will start with an overview of post-operative pain, Perioperative and its pharmacology and therapeutic indications, a pain management course on orthopedic surgery and the use of Perioperative, tolerability and safety overviews, and the possible use for cancer pain. Inadequate pain control is reported by a majority of patients. Oderda et al. In a study published in 2012 pointed out that the pain intensity is the most during the first 48 hours following surgery. Pain, as we describe it by Stephen and Philos and Masad et al., were unanimous in heralding post-operative pain management deficiencies that are due to inadequate analgesic regimens. Shug and Chong presented an alarming percentage of patients, around 80% and above, that experiences moderate pain during the first 24 to 48 hours after hospital discharge. Of these patients, 80% experienced acute pain after surgery, and 86% had moderate, severe, extreme pain, with more patients experiencing pain after discharge rather than before. Several opportunities are now laid for multimodal analgesic techniques and intervention that was recommended by Killet and Professor Shug et al. Surgical intervention plays a key role in promoting survivability as per the Bass et al. Study. The most common treatable surgical injuries are those of trauma, and most of all, like obstetric emergencies and congenital anomalies. Inadequate pain control in a study done by Affelbaum et al., 82% again, consistent, reported that they had experienced some or any type of pain from the period after surgery until 2 weeks after discharge. Of these patients, 47% had moderate pain and 39% experienced severe and extreme pain at some time during the post-surgical recovery period. Inadequate treatment of acute post-operative pain may lead to a range of long-term adverse physiological and psychological changes, but most importantly, acute pain may lead to peripheral central sensitization and neuroplasticity that can lead to the development of chronic pain. The incidence of chronic pain varies by surgery type, and these are the examples of them. The most common and the highest incidence of chronic pain are noted with amputations and thoracic surgeries. And the estimated incidence of chronic severe pain are also found in those types of surgical interventions. Many patients experience post-operative pain, and in a surprising but reliable source, studies made more than 10 years apart by Applebaum and Gunn arrived at almost similar outcomes. Post-operative pain is present within 24 to 48 hours after discharge, with majority having felt any type of pain like 80% or more, with the persistence of moderate pain accounting to a consistent number of more than 45% of respondents. This study was considered in patients in around 105 German hospitals. And the 40 procedures with the highest pain scores, take note, obstetrics being number one, and 22 orthopedic trauma procedures on the upper extremities were noted also. Patients also reported high pain scores after many minor surgical procedures such as appendectomy, cholecystectomy, hemorrhoidectomies, and tonsillectomies because of inadequate pain control and pain regimens. A number of major abdominal surgeries that were seen now resulted in the comparatively low pain scores, probably because of sufficient epidural anesthesia and analgesia. For patients who reported pain before and up to 2 weeks after discharge, Applebaum et al. Noted the predominance of moderate pain reporting, while almost half of the total number of patients' surgeries were done on an outpatient basis. This slide shows how not a single drug regimen, but the multimodal analgesic approach can reap multiple benefits not only for the patient, but for the entire healthcare system. A balance must be tilting towards addressing patient pain issues while minimizing opioid use and opioid-related side effects. The use of multimodal analgesia is rapidly becoming the standard of care for preventing pain after ambulatory procedures at most surgery centers around the world. Multimodal analgesia in postoperative pain management utilizes opioid and a variety of other pain medications, including COX-2 inhibitors, to improve analgesia, opioid-sparing effect, and the reduction of opioid-related adverse events. We note that COX-2 inhibitors are present in these uh, choices as embodied by Perioperative. Armitage stated that slapping the patient on the face and telling him or her that the surgery is over is a complete inversion of the truth, because as far as the patient is concerned, it is just often the beginning of his suffering. Effective management of post-operative pain still poses some unique challenges in as much as we resort to opioids as the mainstay of our post-op regimen, but it cannot be helped that it is not devoid of any side effects as seen here in this slide. Cyclooxygenase catalyzes the initial step of arachidonic acid metabolism in prostaglandin production with two distinct isoenzymes, COX-1 and COX-2. With COX-1 maintaining body homeostasis by gastric integrity, renal function, and platelet aggregation, and COX-2 dealing with inflammation and pain. The drugs COX-2 specific inhibitors like Perioperative are comparable with that of conventional non-steroidal anti-inflammatory drugs, that they have no anti-platelet activity at therapeutic dosages with reduced gastrointestinal side effects compared with other NSAIDs. Joshi et al. Published recommendations for management of postoperative pain as follows: the use of multimodal analgesic techniques, minimizing use of opioids, increasing the use of non-opioid agents, utilizing regional anesthesia whenever possible, and use of evidence-based procedure-specific pain management guidelines or prospect where available. It is important that the goal of any pain therapy should be the ability to improve perioperative outcome in ambulation rather than focusing almost always at a specific pain score. Responding to the question why coxibs led to Shug et al. To provide evidence of its advantages in multimodal approaches, opioid reduction, and comparative competitiveness versus NSAIDs, such as less bleeding after surgery, short-term use in 5 to 7 days with no increase in gastric ulceration, and better risk-benefit ratio as discharge analgesia. PROSPECT stands for Procedure-Specific Post-Operative Pain Management. It's an international collaboration of anesthesiologists and surgeons, providing practical procedure-specific pain management recommendations, as endorsed by the European Society of Regional Anesthesia and other anesthetic bodies like the New Zealand and the Australian College of Anesthetists. It deals with procedure-specific outcomes based on type, intensity, and the duration of pain as interposed between the type of surgery. Its basis is effective management of post-operative pain by recommendation, basing it on systematic literature reviews, clinical practice observations, and transferable evidence from other relevant procedures. Prospect are as exampled here by the different recommendations as of the present. And one recommendation is the treatment of pain for post-total knee arthroplasty, wherein insufficient evidence was gathered between the use of GA and spinal and coupled with the use of femoral block and COX-2 selective inhibitors for the control of pain. Morphine, as combined with spinal anesthetic, was not recommended because we have seen that the moderate to severe pain is very common. It may lead to chronic pain, increasing healthcare costs, and multimodal analgesia techniques has a promise for the treatment of acute postoperative pain and reduction of the prevalence of chronic pain. Parecoxib is not the main drug or effector drug component, but acts as a prodrug that will be transformed into the active form valdecoxib approximately 30 minutes to 1 hour after IV administration. Conversion into the plasma of injected parecoxib into valdecoxib as stated within 30 minutes of administration and will persist in a steady state before it starts to decline on the 12th hour. In a clinical trial demonstrating the analgesic activity of IV parecoxib compared to ketorolac or morphine by Bicassi et al., single-dose 40 mg parecoxib provided significantly better pain responses to placebo or morphine 4 mg and was comparable to ketorolac 30 mg. Parecoxib has been studied in many types of surgeries, as seen also in this slide. Rasmussen compared the analgesic effectivity of single IV dose of parecoxib 20 and 40 mg, morphine 4 mg, and ketorolac 30 mg in unilateral total knee replacement surgeries. A placebo or parecoxib was given 6 hours after discontinuation of PCA on the first post-operative day. The level and duration of analgesia were significantly superior with parecoxib than as compared to morphine and were similar for parecoxib and ketorolac. It was concluded that IV parecoxib sodium 40 mg is as effective as ketorolac 30 mg and more effective than morphine 4 mg. This study compared the opioid-sparing effectiveness and clinical safety of parecoxib sodium over 48 hours in routine total knee replacement surgery. Patients were randomized either receiving parecoxib 20 mg or 40 mg placebo, and at the completion of surgery was given at 12, 24, and 36 hours. Morphine was given as PCA or bolus doses and the patients receiving 20 milligrams or 40 milligrams of Parecoxib consecutively consume around 15.6 and 27.8% less morphine at 24 hours than patients taking placebo. Parecoxib in combination with a continuous femoral block, which is in fad today, provides superior analgesic efficacy as compared to placebo in a succession of hours from 4 hours post-surgery up to 36 hours post-surgery. Parecoxib is opioid sparing, as evidenced here after a total hip replacement as compared to a placebo by reducing the amount of morphine that was given or taken on day 2. Hip replacement surgery again, another evidence of its opioid-sparing effect of Parecoxib at the 36-hour, wherein a 20 milligram and a 40 milligram dose has caused reduction in morphine use at 22.1 and 40.5% respectively, as compared to the placebo. It is an effective analgesic as seen in orthopedic surgeries, and it reduces pain and is opioid sparing. Parecoxib demonstrates effective post-operative pain relief as a single dose or a multiple dose in different types of surgery. The most common side effect of Parecoxib, as noted in 1 in 10 people, is nausea, and it may affect up to 1 in 100 people with the following signs and symptoms. It is well tolerated, as seen here as compared to the placebo with the different doses of 20 and 40 milligrams, that has exhibited only nausea, headache, and vomiting as its most common side effect. In a systematic review that was done by Barden et al. In 2003. Parecoxib has a low incidence of upper gastrointestinal events as compared to ketorolac, with ketorolac producing more gastric ulceration and duodenal ulcer problems as compared to Parecoxib when they were administered in a 5 to 7 day consecutive trial. It is well tolerated and associated with low incidence of adverse events because of data that was given to them, 70 million units sold in a 12-year evaluation period. Contraindications to Parecoxib are cardiovascular conditions as follows, or the history of hypersensitivity reactions, peptic ulcerations, inflammatory bowel disease, severe hepatic impairment, and the treatment of post-operative pain following coronary artery bypass graft, or in the third trimester of pregnancy or breastfeeding. Considered in special populations like in the elderly greater than 65 years of age, a half-dose recommendation is given for patients weighing less than 50 kilograms, hepatic impairment of moderate level using the lowest recommended dose, or with severe impairment totally contraindicated. Renal problems that are of severe impairment, initiate the lowest recommended dose and monitoring of kidney function. Children less than 18 years of age are not indicated or is not indicated to give Parecoxib because there is no data in the pediatric populations as of the time being. Parecoxib can be co-administered with other analgesics, but it is not recommended to co-administer it with low-dose aspirin, less than 325 milligrams, because it may be associated with an increased risk of gastrointestinal adverse events. Therapeutic indications for Parecoxib starts with an initial dose of 40 milligrams IV or IM, continued every 6 to 12 hours with 20 to 40 milligrams intravenous or IM is required. It should not exceed 80 milligrams per day and is limited to 2 days only. There is a possibility of the role of Parecoxib in the control of cancer pain. In a study made in the role of selective cyclooxygenase 2 inhibitor of pain and enhanced recovery after open hepatectomy, it was noted from its study that they were divided randomly in a control group, patient-controlled analgesia, and an experimental group using Parecoxib and PCA. An analysis of the perioperative serum biochemical profile, cytokine concentrations, and transforming growth factor beta, as well as post-surgical analgesia, recovery, and adverse effects were done. Parecoxib reduced systemic ESR, interleukin 6 and 4, and TGF-beta concentrations 48 hours after surgery, indicating that both COX-2 pathway and an immune cell balance effect is involved in surgery-induced inflammation. Another study the effect of perioperative parecoxib on postoperative pain for patients undergoing transcatheter arterial chemoembolization or TACE for hepatic inoperable hepatocellular CA was seen to utilize parecoxib. This study aims to assess the analgesic effect of parecoxib for postoperative pain. And pain scores, percentage distribution of pain categories, and morphine consumptions were significantly lower in the parecoxib group than in the control group. Fever scores were likewise significantly better in the parecoxib group. Quality of life scores in the parecoxib group were significantly better than those in the control group. In a study in the effectiveness of parecoxib sodium combined with a nerve block like a transversus abdominis plain block after hepatectomy or hepatocellular carcinoma, the pain scores in the study group were significantly lower compared with the control group in the first 3 post-operative days. No significant difference were found between two groups in terms of adverse events. In the study group, the number of cases of postoperative ambulation was significantly more than the control group. Parecoxib sodium combined with top block effectively reduced postoperative pain in this study, improved ambulation, improved gastrointestinal function, and shortened hospitalization time following hepatectomy in patients with hepatocellular carcinoma. Another study using intravenous injection of parecoxib combined with a transversus abdominis plain block again in a strategy of enhanced recovery after radical resection of colorectal cancer was also done. The objective of this study is to investigate the effect of this parecoxib introduction together with a plain block in a strategy of enhanced recovery after surgery for patients with radical resection of colorectal cancer. The first out-of-bed time activity, the mobility of the intestines, and the hospital stay time of the parecoxib and the top block group were significantly shorter than those of the other groups examined, while the control group was all significantly higher and also exhibiting less effect. Complication rates in all strategy groups were significantly lower than in the control group. However, no significant difference were found among strategy groups. In all this taken into account, the decision to use parecoxib should be based on assessment of the individual's patient's overall risks. But on the basis of overall safety, based on the EMEA committee, it concluded that the benefits of parecoxib outweigh the risk, not only for the use of control of post-op surgical pain, but also has a promise in dealing with chronic or cancer pain in the future.